So we should probably start. Because it's past 9. We've got some people online. I'd just like to introduce ourselves. I'm Bill Abelson, and on behalf of BC Pediatric Society, would like to welcome you to this session on collaborative strategies to prevent meningococcal disease in British Columbia. We're not totally original. This was done in Ontario by our colleagues in Ontario Pediatric organizations, and they had a symposium and came up with some ideas, and we thought we would copy them. We don't usually copy Ontario, we usually lead, but in this case we'll try and bring a fresh perspective. We've got I see we've got Nanaimo online. There actually are some people there, at least one person, maybe 2 people in the room waving. That's great. Welcome. We've got an empty New West room as far as I can tell on camera. I know there looks like a shadow in the background, somebody moving there. Excellent. Welcome. And a couple of other sites maybe will be signing in over the morning, and hope so anyway. I think we've got an excellent lineup of speakers. We're going to start off with epidemiology with national information, but also specific to BC, and move into some strategies about how to prevent meningococcal disease. We're then going to go to Quebec, where they have probably more experience with the vaccine than just about anywhere in the world because of an outbreak there and a campaign using Bexsero or 4CMNB vaccine there. And then we're going to go some of our local leaders in terms of the public health roles in how decisions are made about new vaccines and what some of the issues are with unfunded vaccines, who gives vaccines in this province, and educate us more about how to improve vaccination in general, but also specifically the unfunded vaccines before they're publicly funded. I'm lucky. I've given myself lots of time to chat, and though I do love talking, I'm actually going to cut myself short so that we can give some of the other speakers more time. I'm going to try and keep them to their time periods, but we'll try and fit in a little extra here and there. And so with that in mind, I want to start with Julie Bettinger, who's very well known in terms of not just meningococcal research, but the epidemiology of infectious disease around the country. She works at the Vaccine Evaluation Center as a member of the Department of Pediatrics here at UBC, and is a Michael Smith Foundation for Health Research Scholar. Her interest is infectious disease epidemiology, specifically meningococcal and pneumococcal invasive infections. And she's been the epidemiologist for the IMPACT, that's the Canadian Immunization Monitoring Program, active for a number of years. And that's a program that has active surveillance, active surveillance in 12 tertiary care pediatric hospitals across Canada. So with that in mind, we're going to start with Julie, and I've told her specifically we want to know what's happening with the epidemiology, not just in Canada, but BC specifically. So thanks very much, and welcome to Julie.
Morning, everyone. Thanks everyone for getting up this early to listen to these talks. I'll try to set the stage for what's going to come later today and give you the background on what we see with invasive meningococcal disease. I do have some disclosures to make. Novartis and GSK provide grants to the Canadian Pediatric Society for impact surveillance. Let's see, I do a lot of clinical studies looking at the various vaccines that we have in Canada, and these are from Novartis, Baxter, GSK, Sanofi, Pfizer, and Merck. These are post-licensure or post-approval vaccine studies and don't involve funding from industry. And then I do work with both the Public Health Agency of Canada and the Canadian Pediatric Society. So those are probably the critical disclosures you need to know from me. So what I'm going to cover today is I hope that when you walk away from my talk, you'll understand the epidemiology of invasive meningococcal disease, both in Canada and in British Columbia, and that you have an understanding of the impact of meningococcal vaccine programs, specifically the serogroup C programs, because that's the one that's been in place long enough, and we haven't updated to really look at what it's done. So this slide goes back to 1924, which was the first year that we collected uniformly information on invasive meningococcal disease in Canada. And what you should notice immediately upon looking at this is that this is very much a cyclical disease. It goes up and down. About every 10 years, you see real large epidemics occurring. Some in terms of the 1930s, 1940s, greater than other years. But in general, you have this up-down pattern consistently with this disease. In the earlier part of the latter century, it was primarily driven by serogroup A. We saw a shift sort of in the 1970s to more serogroup C disease, and then in the 1990s, we started seeing some serogroup Y. So you can also see on this slide the number of cases shown in green, as well as the incidence. And again, you do see variation over the years. The polysaccharide vaccine was approved for use in 1983 in Canada, shown here. And then in the early part of this century, you can see that monovalent C vaccine, the conjugate C vaccine, was approved and started being used in about 2002, and the quadrivalent vaccine in 2006. So if we look a little bit more closely at sort of the last few years here, you can see that we have about 200 cases a year on average, some years slightly less, as in the 2010-2011, with an incidence of about 0.5 per 100,000. So if we look more closely at what the specific serogroups are that we see circulating, again, you can see most of the recent cases are caused by serogroup B disease. The incidence around that, for that particular serogroup, is about 0.25 to 0.30 across Canada. If we look at serogroup C, you can see it's declined over the years. We now have an incidence of about 0.05 or lower each year in Canada with this disease, so very few cases, similar to what we see with serogroup W disease here. Serogroup Y has remained relatively stable with an incidence of between about 0.05 and 0.1 each year. So what you should also know about serogroup C disease or about invasive meningococcal disease is that it does vary by region. And I'm showing the slide from Quebec because we're going to hear some information later about the immunization program that they implemented in Quebec. And what's important to understand is you do see differences. Quebec's the best example of that. So what we see in Quebec is probably 90% of the disease is caused by serogroup B. It affects not just young children, which is the typical picture that we see with serogroup B, but it affects all age groups, particularly their adolescent population. If you look in the slide here, the last several years, 2008, 2009, 2010, the years that I have the most recent data for, you can see that the vast majority of disease shown here in the purple was serogroup B. They had maybe 1 or 2 cases of serogroup C in their older adults in those years. And then some other very random serogroup X, serogroup 29E occurring. But really the vast majority of disease that they've dealt with over the last few years has been serogroup B. And it's been up to epidemic proportions in some of their western regions. And we'll probably hear a bit more about this with some of the later speakers. But it's important to understand that because this was a large motivation for them putting the serogroup B program in place. They were really seeing the disease incidence and the reason to have it there, particularly in the areas where they placed it. If we look at British Columbia, this slide is compliments of Monica, thank you, from 2001 to 2014. And again, what you can see here is over that time period, we've seen a steady decline in all forms of the disease, but particularly in our serogroup C disease. And if we get out here to 2014, there were a total of 5 cases of Y, 1 case of W, 1 of C, and 6 of serogroup B. And this is fairly consistent with what we're seeing in a lot of the other provinces, with serogroup B being, at this point, the leading cause of cases that we see in most of the regions. Not to the same levels that they see it in Quebec, but it is one of the most frequent forms of the disease here. But when we say frequent, we're talking 6 cases for the year. So this overall is a very rare disease, and we're not talking about huge numbers of individuals that are being affected. So if we look at the age distribution, this is fairly typical for the serogroups. You can see that the vast majority of cases usually occur in children younger than 1 year of age, followed by those 1 to 4 years of age, and then you have the secondary peak in sort of later adolescents, early young adults. I've shown here the numbers for Canada overall, and then specifically for BC in 2013, to just give you a sense of how BC compares to the national figures. The other interesting thing to note is that when you get out here to 60 years of age and older, you do start to see a very small uptick as well, and this is primarily driven by serogroup Y. So the other thing that's important to know a little bit about when you're thinking about immunization programs is the carriage of the disease. Because if you have a vaccine like the conjugate C vaccines, which can actually affect carriage, your vaccine can have a much larger impact at a population level. You're then able to protect not only those you immunize, but those who do not get immunized. Your indirect protection can be much greater. So in looking at 89 studies in 28 countries, what they found was that the majority of carriage for all of the serogroups is really in this adolescent or young adult population age. So about around the 20-year-old mark. That's where this organism is found. So if you could have a vaccine that would knock this out in this age group, you could potentially eliminate that disease. So I'm going to touch a little bit on the burden. I'm sure many of you have probably seen these cases. You know what they look like. You're familiar with the burden of disease. It's not something that you want to have turn up in your practice, but I think it's good to sort of put some of these pictures into the broader context. So the mean length of hospital stay, and these data are coming from IMPACT, and so this is both in adults and children. The mean length of hospital stay generally for a case of invasive meningococcal disease is 8 to 11 days. ICU care is required in about 60 to 75% of the cases, and the mean length of stay in the ICU is about 3 to 5 days. Mortality ranges from about 5% to 13%, and again, this often depends on the age of the person and the type of serogroup that they're infected with. And then sequelae is about 20% of the cases. What we see with this is that the mortality rate is actually lower in children, but they are much more likely to be left with some severe sequelae that can potentially last very long term and be permanent. So if we look at it more by serogroup, I've shown here the 3 most common serogroups that we see in Canada, so serogroup C, B, and Y, to give you a sense of sort of how it breaks out slightly differently when you start talking about the burden and what we're seeing. So again, you can see with serogroup C, and some of these data are collected post-immunization programs, so we're seeing a bit of the effects of that on the data that I'm showing you here. But you can see about 3% of the cases are occurring in children younger than 2 years of age versus 30% of the cases of serogroup B and 8% of the serogroup Y cases. So you do see some differences in terms of the age distribution of these serogroups. For sort of the next age group, you can see it's about a third, slightly under for some of the serogroups. And again, this is really, the bulk of these cases are occurring in the older adolescents here. When we look at adults, again, about 70% serogroup C. So serogroup C is not just a pediatric infection. That's probably the other key thing to take away from this. It affects adults as well, and it's a lifelong, you have a lifelong risk for this. It's not something you grow out of. If we look at serogroup B, it's about a third. Serogroup Y, again, is about a third. And then when we get to to adults over 60 years of age and older, you can see that it's about 11% of the serogroup C cases occur in that age group, 6% of B, and then 31% of the Y cases. So again, I mentioned that we start to see this uptick in that age group with serogroup Y, and you can really see it in the figures here. So mean length of hospital stay is slightly longer for serogroup C, about 14 days. Serogroup B is about 11, and serogroup Y is about 10. ICU care is required for 71% of the C and 61% of the B cases. Interestingly, serogroup Y only 36%, so there are some differences there. Mean length of stay is slightly longer for C, 5 days for B, and just over 4 days for serogroup Y. Again, as I mentioned, the mortality already, 13% for serogroup C, 5% for B, and about 2.5% for serogroup Y. Sequelae, about almost a quarter of the cases who end up with serogroup C, about 20% with serogroup B, and about 8% with Y. So we do see some differences by serogroup. These aren't necessarily significant, but they're worth noting that in a sense, serogroup Y can be less serious than, say, serogroup C. I think that's a fairly, observation is pretty consistently borne out in the data. Okay, if we look at the types of sequelae, and again, this is coming from IMPACT, you can see that for neurologic complications, we don't have any in our data that resulted with serogroup Y. We had about 3% of the serogroup B cases and about almost 8% of the serogroup C. Deafness, about 1% of serogroup Y, about 7% of the B, so you see slightly more deafness in children who have serogroup B, and 6% of the serogroup C cases. Skin scarring in about 2.5% of the serogroup Y, 6% of B, and 8.5% of C. And then amputations were required in about 1% of serogroup Y, 4% of B, and 8.5% of the C. So that's what the sequelae look like with this infection. Okay, so if we want to look at the impact of meningococcal vaccine programs, as I mentioned, we really need to look at serogroup C. That's the one that's been in place the longest and that we have the most data on, and we're best able to really see the effects both in Canada and internationally. So this lovely patchwork quilt slide illustrates the implementation of the programs across Canada. As you can see here, it ranged from 2001, starting in Quebec, to 2007 in the Northwest Territories. Right? Yes. I get a little confused when I look at the territories, yeah. And you can also see the range of doses that we have here. So the first number is representing the number of doses that's given in infancy or to toddlers. So in BC, we have a 2-dose program. The first dose is given at 2 months. The second dose is given at 12 months. The plus indicates whether or not there's a booster dose given to adolescents. And again, the age at which the booster dose is given varies from province to province. Some do it in 6th grade, some do it in 9th grade. But you can see in BC, we have a 2-dose infant program, so 2 months and 12 months, followed by a 1-dose adolescent program. Alberta has 3 doses that they give in infancy, so 2, 4, and 12 months. And they give 1 dose to their adolescents, and the asterisk on here represents the quadrivalent vaccine. So in BC, we're using the monovalent conjugate MenC vaccine, and in Alberta, they're using quadrivalent. So if you take a look at this, you can see that about half of the provinces are giving their adolescents the quadrivalent vaccine. And about the other half of the provinces, Quebec, BC, are using the monovalent C vaccine. And then we've got our territories that don't provide an adolescent dose, but they do recommend it if their adolescents travel down to these provinces for university. So, and then the NACI recommendation pretty much encompasses what you see here on this map. So they recommend 1 to 4 doses of the monovalent C vaccine in infancy, which accommodates what we're seeing across the provinces, and 1 preteen MenC or MenACWY dose, with the caveat that it should be dependent on the local epidemiology. Okay, so how does Canada compare to other countries with MenC immunization programs and to countries without programs? So this slide, the red line, is showing you countries with routine MenC vaccination, and these are Belgium, Iceland, Ireland, Netherlands, Spain, and the United Kingdom. And then countries in Europe without routine programs, so Austria, Czech Republic, Denmark, Estonia, Finland, France, Germany, Greece, Italy, Malta, Norway, Poland, Slovenia, and Switzerland. And then Canada is shown here in the black line. So first thing you can note is that clearly the European countries that implemented programs were starting with at a much higher incidence point than we were in Canada when we put our programs in place. They've seen significant declines of the disease over this time period, but we've seen declines as well. And I think what's interesting to note here in 2006 when these data were compiled, that the declines were lower. The countries that had put programs into place now have a lower incidence point than those without. So if we look more specifically at what we were seeing in Canada and take it out to a longer point, sort of 10 years post MenC introduction, you can see the various serogroups here on this slide. So MenC is shown here in red. You can see what it looked like before programs were in place. This is the incidence here. As they were being implemented, and then out here sort of 8 and 9 years, we virtually eliminated serogroup C disease. If you look at serogroup Y, as I pointed out in the earlier slide, it's remained relatively stable over this time period. And then these are the non-BCYs, so W, an occasional A, some of those other random serogroups that pop up. What you should also note from this slide is the increase in serogroup B disease over this time period. A lot of this out here is being driven by Quebec. This is national data. But we have seen the bulk of the disease that is occurring now in Canada is caused by serogroup B. If we look at it by province, you can see Quebec is in the black line here, Alberta is in this dashed line, and British Columbia is in the dotted line. And these were the three provinces that had the programs that started first in Canada. So you can look at the declines over this time period in these provinces, and you see they come down steadily and are now all around 0.05 per 100,000, and some slightly lower than that if you look in Quebec. These are the other provinces, just as sort of a comparison. So, and if we look specifically, again, back to serogroup, back to British Columbia, what you can see is for this most from 2001 to 2014, you see that we had 27 cases in 2001, down to 1 or 2 cases over the last 3 years, 0 cases in 2011. Actually, going back further than that, over the last 5 years. So fairly significant declines, even in just the number of cases, let alone the incidence. So decreasing from over 1 per 100,000 down to about 0.2 per 100,000. And this incidence here is all invasive meningococcal disease, not just the serogroup C. So finally, to sort of bring it back to this age distribution, if you're going to think about where you might want to put a program into place, what do you need to think about? Probably where the disease is occurring and how you might best control it if you have a vaccine that can protect against carriage. So as a lot of as the serogroup C program that's been in place in Canada, it's targeting this age group here, either in some of the provinces, those who are younger than 1 year of age or those who are 1 year of age. And it's targeting this age group here, sort of the 15 to 19-year-olds, some of them getting it right here in the 10 to 14-year age group, so they're protected when they enter these years. So in summary, invasive meningococcal disease is at historic lows right now in Canada. We've not seen incidence this low since 1924. So that's pretty remarkable. And it is, though, a cyclical disease. It does vary by serogroup, and it does vary by region. So we do need to keep an eye on this. It's not something that we've completely eliminated, and we do need to know what's happening with it because it can change quite rapidly. Serogroup Y tends to affect older adolescents and young adults, and older adults, those who are 65 years of age and older. Serogroup B tends to affect children younger than 5 years of age, unless you're in Quebec, where they've got more of an epidemic situation going on, and then they're seeing it across all of their age groups. MinC immunization programs have been successful. We've seen a virtual elimination of serogroup C disease across Canada and in BC. And herd immunity can be a very important component to consider when you're putting vaccination programs in place. So thanks.
So thank you very much, Julie, for that information. Next speaker is Simon Dobson, who is just absolutely gleeful that Julie was finishing so early because he just loves to talk, and which is a good thing because he's actually a very good speaker. Simon's a clinical associate professor at the University of British Columbia and head of pediatric ID there. And he's trained both in the UK and Baylor College of Medicine in Houston. He's been a member of NACI. He works at the Vaccine Evaluation Center at BC Children's and has a vast experience with immunization. One of his interests that I quite enjoy hearing stories of is his adverse events clinic, where he deals with specific families who've had problems with vaccines and deciding whether their children should be vaccinated and then giving the vaccines, which is always a fun thing. And I really look forward to hearing Simon talk about strategies for vaccination for the 21st century with respect to meningococcal disease. Yeah.
Great. Thanks very much. Thank you very much, Bill, for that introduction. The AV guy, when he was loading my talk up, said, that number of slides, really? And so I do have a lot of slides, but I'm going to go through this fairly rapidly. Let's start with my conflicts. And so although the instructions were for the past 2 years, I'm not sure that conflicts of interest ever go away. And so this is my sort of generic one, which is because I work at a vaccine evaluation centre, of course I do clinical trials with pretty much all of the vaccine manufacturers. So I'm sort of equally conflicted, I hope, across the board. But one of the things that has been happening over the last decade is a contraction of vaccine manufacturers. And the public is sort of asleep at the switch because in terms of competitiveness, that's going to go out the window. And I think public health is very concerned about the price of vaccines that are coming down the pipeline because there is no competition. And I'll come back to that theme later on. I have been on advisory boards in the past for vaccine manufacturers, and there's one talk I gave at a symposium for GSK, mainly because Julie couldn't do it, but that sort of hung around my neck for years. Relevant to this talk, it should be pointed out that GSK acquired Novartis vaccines, and that's a good example of contraction. Right. Oh, the other thing I was going to say is, of course, my main conflict of interest is on pediatric infectious diseases. So I see the kids with invasive meningococcal disease in BC. And as part of that, vaccine hesitancy stuff I do in clinic, I have to keep on reminding myself that everybody perceives risk differently. And in the first half of this talk, it's going to be obvious that my perception of risk of meningococcal disease is way greater than everybody else's because I see the cases. And so I assume that invasive meningococcal disease is way more important than the epidemiology would say it is. And it needs the objectiveness of public health, particularly Monica Naus, who's speaking later on, to kind of bring that objectiveness to the decision-making about vaccines going into public programs. So Julie showed that map, and I've got the same map in the next slide, but try to explain to non-Canadians that there is no such thing as a Canadian immunisation schedule, that each province makes its own decisions. Meningococcal disease is rare. The numbers, the numerators, are even smaller when you divide it up province by province. And so you've got individual provinces making decisions based on very small numbers, and you end up with stuff all over the map. And so, this is just for meningococcal C vaccine. You've got different schedules. You've got the adolescent vaccine either being only Men-C or in some provinces the quadrivalent. And by dint of my job, I end up having to go to meetings in Toronto, Montreal, Ottawa, and on the aeroplane, I'm thinking, all these screaming kids who, invariably end up in the seat next to me, their risk of acquiring meningococcal disease is not province-specific. There is movement between provinces, and, how come in a Canadian system where we all value equity, which meningococcal vaccine you get depends entirely on which province you happen to be brought up in. So not only do they use different schedules, but as these vaccines come online into programs, varies. And so Quebec was very quick to use Men-C vaccine because of their outbreaks. There was outbreaks in BC, so we were relatively early adopters. But the ones in the middle, provinces in the middle, were relatively late adopters. And Manitoba always seems to be the last, and I don't quite know why that is. And so, yes, all these different schedules, different products are being used. So vaccines, as they come through the pipeline, and here's a list of examples of vaccines that have recently been licensed. some of them in public programs and some of them not, particularly zoster vaccine at the bottom there, and not all provinces are using rotavirus vaccines. And so, what is the process that happens in Canada? And the answer is Health Canada does the licensing based on the manufacturers presenting their file to Health Canada. Once it's licensed, then there's a statement from the National Advisory Committee on Immunisation that gives recommendations about its use. There's then another committee, the Canadian Immunisation Committee, which is an FPT, Federal, Provincial and Territorial Committee, that looks at other elements. And then the bottom line is that at provinces, it's the provincial decision as to whether they're going to introduce a program. And so you'd like to think this thing was streamlined, and the MenB vaccine is the prototype for getting NACI and the CIC to do this together. But it's still provincial decisions as to whether a vaccine goes into programs. And so we have this framework in Canada, which the rest of the world admires, and many sort of middle-income countries in the world have looked to the Canadian framework to make decisions about introducing new vaccines in their own countries. And it's called the Erickson-de Walds model, which we all adhere to. And so, burden of disease, vaccine characteristics. So Julie's talked about burden of disease. I'm going to talk a bit about vaccine characteristics and obviously immunization strategies. But things like cost effectiveness, acceptability, feasibility, those are not things that NACI is doing. It's the Canadian Immunisation Committee that's doing. And so it is a very sort of split up system, and even working within it, I'm not sure exactly which bits connect with others. And then these other bits, equity, ethical considerations, political considerations, and then the legal, and by legal I sort of mean, are you going to get sued, are things that sit with the Canadian Immunisation Committee but may not be considered specifically. And hopefully this particular slide is what's going to get talked about in the panel discussion later on. So Julie's talked a little bit about the disease itself. She talked a lot about burden of disease. But for the clinicians, this is a tricky disease. It's easily misdiagnosed in its early stages. If you miss the early signs, there's rapid progression, there's significant morbidity and mortality, and by and large in pediatrics, we don't see a lot of death. But this is a disease that does cause death, and so that impacts on my day-to-day clinical experience. The significant morbidity and morbidity is seen in the follow-up clinics. And so as general pediatricians, these accumulate over time, and you see them until they fall off the pediatric age range into that morass that is the lack of care in late teens, early 20s in the community. So the burden isn't just the acute disease, it's the consequences that you see over the next decades. We've all seen these things, and when I talk about vaccine hesitancy, one of the key things about perception of risk is how easily accessible it is to the imagination. And so that works for both the disease and for your fear of side effects of vaccine. And so for all of us in pediatrics, this presentation with horrible gangrenous limbs, a blood pressure that you just cannot get out of the boots, and progression to death is something easily accessible to the imagination because we've experienced it. And so we overestimate the risk of disease in the community. It's a strictly human pathogen. Asymptomatic carriage is common, which Julie touched upon, and herd immunity is everything. And so that worked very, very well for MenC vaccine, but there is not a lot of information on herd immunity with the MenB vaccine. And that's one of the key unknowns. And what little information there is suggests that actually there isn't a great deal of herd immunity effect on carriage from the Men-B vaccine. But really, we just don't know that. And it would be nice to think that the Quebec experience is going to tell us something about that. It's respiratory spread. The incubation period is very short, hence the necessity to go on and give either prophylactic antibiotics or immunization to close family contacts. Risk factors for meningococcal disease, babies, because their immune systems for this particular pathogen aren't really great. There's a rapid reduction in the first year of life of passively acquired maternal antibody. So it's not surprising that infants are particularly at risk. And then the next risk group is adolescents, where they're sharing respiratory secretions, in crowded bars, shouting at each other, hence sort of droplet spread. There's an associated with smoking, and anywhere where large numbers of these kids are together. And then travel is the other risk factor to areas where you've got much higher incidence of meningococcal carriage. And although if you look at the NATI recommendations for the Men-B vaccine, they do recommend it for people with specific immunosuppression, children who are asplenic, but really that's not the nature of the disease in the community. It's the perfectly healthy child who, out of the blue, goes to bed well and is near death in the morning. And it's that suddenness of it that is a worry to clinicians, but also it speaks to public fear as well. This has a very high profile in the community. And so the early signs are very non-specific, could go with any sort of respiratory viral illness, but if it's the progression that's the key thing. And unfortunately, children who present early in the course to the emergency room with very non-specific symptoms are highly likely just to be patted on the head and sent home. And that's when the lawyers are knocking on your door for the emergency room docs. And so, you know, they're very cautious about not missing this, because a number of the patients do not have the characteristic rash, particularly in the early stages. And they may even have a maculopapular rash that doesn't become purpuric until later. And so, you know, the clock is ticking in terms of progression of symptoms. So Julie's talked about incidents of meningococcal B disease. Like C has been fantastic. It's, you know, disappeared pretty much. And in terms of cost effectiveness, I suppose I'll put this in here. You know, if you're an accountant at the Ministry of Health, and you'd be saying, well, you know, why are we spending all this money on meningococcal C vaccine when, you know, it's a disease that doesn't exist? Well, you know, trying to remind everybody that, for example, measles control, like as soon as you stop getting good levels of measles vaccine coverage and you go to Disneyland, you know, then you're going to get measles. So it's the same argument with men's C disease, but it's something that you've constantly got to remind the purse holders that even though the disease is not present, it's not present because of vaccination. And compared with what happens with the latest drug since lunchtime, you know, for overweight middle-aged men like myself, that automatically get put through the system, the problem with vaccines is that you're paying a lot of money for nothing to happen. And somehow that's a very difficult thing for purse holders to understand. So Julie did not put this slide in, so I'm going to just talk about this for a moment. But Manish Sadarangani, who was an ID fellow here, and Julie wrote this paper looking at risk of invasive meningococcal disease by age bands, so less than 2 all the way up to lifetime risk. And depending on how you look at numbers and how you perceive risk, if you look at the line from the second one up from the bottom, the childhood 0 to 18, a risk of any invasive meningococcal serogroup from 0 to 18 years is 1 in 4,200. For B, it's 1 in 6,200. Now that's, most parents looking at that would say, that is a bit of a risk. That's more of a risk than me, and you're not supposed to do this in terms of vaccine hesitancy. You're not supposed to do comparative risk. But they're going to look at those numbers and say, that is way more of a risk than me having a head-on car crash for which I wear a safety belt every day. And so, you can play with numbers, but that's impressive. And that's the slide that you should print off and be waving in front of families and saying, this is the risk. So Julie showed this, but I put it back up again just to re-emphasize that point, that for the frontline clinicians, for the pediatricians, each one of these is a memorable event. And not a year goes by without me seeing these kids in ICU, talking to parents about their child who's about to die, and in outpatient clinic, the significant morbidity that goes with the disease, even if you survive. So Julie showed these slides. C clearly has been a successful vaccine program by any standard. It's one of the great success stories of the last decade. So MenC programs have worked, lots of schedules going on, and Julie would argue it's brilliant that each province does something different because it keeps her in work. Because comparing which province is doing better by which schedule and which boosting schedule is a very interesting question. And the British, who do, it's all in, everybody does the same thing, they love the idea that Canadians do these comparative studies because it vindicates the decisions that they make. And I'm going to come back to that when we talk about how the British made a decision about MenB vaccine going into schedules. So we're back to the Erickson and de Waal's model. So the vaccine characteristics, which I'm going to talk about next, is it safe? Does it work? That's basically what NACI is making its recommendations on. But also they take a broader view, which is, it's no good introducing a new vaccine into an infant schedule, for example, if it messes up everything else that's being done in the infant schedule. And that's a scientific question in terms of does it affect immunogenicity, but it's also a behavioral question. So if you're putting yet another vaccine into the infant schedule, does that put the parents off from giving the other vaccines? And the safety aspects of that, the reactogenicity question, is very important in terms of acceptability of not just the new vaccine, but whether putting a new vaccine into the schedule is going to put parents off getting the rest of the vaccines. So these are the MenC vaccines licensed in Canada, and the Nymenrix, which is the quadrivalent ACYW, and Menvio, which was Novartis but is soon to be GSK as well. The question is, can a company hold two vaccines? Are they allowed to do that in terms of sort of monopoly? And I think the answer is no. So it'll be very interesting to see what happens between Menvio and Nymenrix now that they're essentially owned by the same company. But a great example of how, because of international global capitalism, we're about to be seriously disadvantaged in terms of choice. Each company would say, my product's better than yours, but really, that's not the point. The point is, does it work in programs? Does it work across populations? And what's the cost? and the experience of all these different Men-C vaccines is they all work well. There's a little bit of difference in terms of, boostability and whatever, but from a public health point of view, they've all worked fantastically. So I'm going to spend a bit of time talking about Men-B vaccine, which was recently licensed, recently the subject of a NACI CIC statement, where they said, no, we're not going to recommend it for widespread use in programs, but if you want to give it, then give it. And that's really the purpose of today, is to say, well, if it's not in a provincial program, that really puts the onus on pediatricians and GPs to discuss it with individual parents. So it's an interesting vaccine. I like it from a vaccine technology point of view because it's different to the conjugate polysaccharide vaccines, which are the other meningococcal serogroup vaccines. So there's lots of different strains, over 8,000 Men-B strains described, and you're probably going to need a different strategy compared with the capsular ones. And the reason is the capsule of Men-B is not immunogenic to humans, and that's because it mimics a human neuroprotein. And even if you could kick your immune system to recognize it, it's probably not a good idea to raise an antibody to something that's already in your brain. And so there's immune tolerance to the polysaccharide capsule for B, and even if you use tricks to get the immune system to respond to it, it doesn't seem to work very well. And so a different strategy had to be developed, which is this reverse vaccinology thing, which is the future of vaccines. Like, even if this vaccine doesn't get to be used widely, it's still been a brilliant prototype for how you develop new vaccines. And so there are two companies. There's Novartis, soon to be GSK vaccines, that has used the 4C Men-B, so 4 components. But there's also a bivalent vaccine that is being developed by Pfizer that's sort of steadily plodding its way through clinical trials. So the 4C Men-B, reverse vaccinology, which I'll describe in a moment. So you've got these 4 different components, antigens, one of which is the outer membrane protein vesicle from the New Zealand outbreak strain, and then these other 3 components. So the vesicles are these little blebs that sit off the outside surface of the Men-B bacteria, but they're very strain specific. So this reverse vaccinology bit, where you start with the genome, you figure out which genes are expressing proteins, you take the proteins, you take the genes expressing the proteins, put them into E. coli, make the protein, stick it into some poor unsuspecting mouse. You then confirm that there is expression within the mouse, and then you take the antibodies from the mouse and confirm that the antibodies of that particular protein is protective in the test tube for the bacteria. And so, having done all of that stuff and crunched these numbers, they end up with 3 proteins that they say perform best. And it's only at that stage that they go and say, well, hang on, what are those proteins? And so, in the old way of doing things, you'd sort of start with the specific binding protein and say, oh, let's go and see if that's protective. But here, they do it the other way around and start with the genes and end up with specific proteins. So what's interesting, of course, is that this is not, some of these proteins are not specific to Neisseria meningitidis. They're also common to Neisseria gonorrhea. And so one of the interesting questions is, can you use these proteins to develop a gonococcal vaccine? Although I think the company's gone a bit sort of quiet on that, particularly with all of this takeover stuff going on. But the other point to make is that although it's described as a Men-B vaccine, it may well be, well, it is, that these proteins are common to other meningococcal serogroups. And so you could take a big picture look and say, well, why are we describing this as a Men-B vaccine when actually it's a meningococcal sort of common serogroup vaccine? And so if you spend an absolute fortune introducing Men-B vaccine programs, when actually you might be able to save money using this vaccine instead of your conjugate C vaccine or your conjugate quadrivalent vaccine. And so there's a lot of interest, at least in theory, that this could be a sort of cross-covering meningococcal vaccine. But, and so this is a huge but, it doesn't cover all Men-B strains. And so we've talked about how provinces have their own individual epidemiology. Well, that's going to be sliced and diced even more to say, well, with each province of your Men-B cases, how many of your Men-B cases would be covered by this vaccine? And that's one of the big points being made in the NACI statement, is that if you don't get great coverage from your Men-B vaccine, are you actually wasting public dollars when actually it's not doing the job it's supposed to be doing? And so it's reckoned that about 2/3 of Canadian Men-B strains will be covered by this 4-component vaccine. And this pie chart shows you what proportion of those strains are covered by 0, 1, 2, or more than 2 of the components of the vaccine. And there is this technology called MATS that very painfully, in terms of time and the technological effort that goes into it, to assess whether your strains are covered by the vaccine. And so that MATS technology was specific to Novartis. They developed it, but one of the clever things that Novartis has done is to make that freely available to countries that want to set this up as part of a national surveillance program. And that technology transfer deal has been done with the National Microbiology Lab in Winnipeg. And so we do have that capacity in Canada. So fortunately, for the talk that's coming next, Marc Lebel, about the Quebec outbreak, the 4C Men-B vaccine is very good at covering the outbreak strain in Quebec. And this map shows the different provinces, what the coverage would be. And so if you look at the far left-hand side for BC, the coverage is somewhere between 30% and 57%. Which actually, isn't great. But of course, things are not static. And so strains come and go. And one of the unknowns, of course, is if you use the vaccine widely, would that put pressure on the organism to select out strains in the community that were not covered by the vaccine? And of course, we've been here before with Prevnar. Did Prevnar 7 lead to the arising of strains that were not covered in Prevnar 7 that got sorted out by increasing the coverage to Prevnar 13? But actually, it's not clear whether it was vaccine that was putting pressure on. It certainly never happened with Haemophilus influenzae type B. There was no emergence of more Haemophilus influenzae type A, for example. And so that's sort of part of the research question when you introduce a vaccine, is to look and see whether it does alter the epi. And so I've made that point that, this is not unusual, like in other vaccines, and pneumococcal, but also human papillomavirus. Like there's no attempt to do 100% of strains. You take your gains where you can. So for HPV, the bivalent and the quadrivalent vaccine covers 70% of the cervical cancer-causing strains. So just to go quickly through the actual vaccine stuff, the clinical trials involve thousands of infants. I'll talk about adolescents later. No severe side effects, although fever was noted after vaccination. I'm going to talk some more about that. The problem was easily solved by giving prophylactic doses of Tylenol. There was no increase in febrile seizures. Yes, protective antibody was found. It was generally thought to be safe and tolerable, which is, one of the key things that is looked at in NACI's statement. So now I'm going to do some boring histogram stuff. So for the 4 components, in green is the baseline antibody response, and then you do your 3-dose infant schedule, followed by a booster dose at 12 months. And, some of the components, you don't seem to get long-lasting memory. So the poor A one, for example, you get a good immune response after your 3 initial doses, but then by the time you give the 12-month dose in whatever that color is, sort of dark orange, that antibody level has dropped off, but then there's immune memory, and you do get a booster response when you give the 12-month one. But that durability of the immune response is one of the cautions in the NACI statement. Like, do we know whether that antibody response is going to be there in enough amount that when you meet Men B in the back of your nose, and if you remember that incubation period of 2 to 10 days, that's a pretty short period of time to mount your immune memory response. And so it's a bit like, it's not exactly the same, but it's a bit like tetanus and diphtheria, where you actually need your toxin antibody for diphtheria and tetanus there and then when you meet diphtheria in the back of your throat or you stand on the rusty nail. So meningococcal disease is a bit like that. You need your antibody there before you acquire the thing in the back of your throat, back of your nose and throat, in order to be able to prevent that invasive step. And so for the infant and 12-month booster program, that is a big question. And after 2, so they have now been followed up over to 2 years, and it does sort of drop off. But if you look at the epi, you really want to protect kids under the age of 12 months. And for adolescents, you want to protect them in those adolescent years. And so maybe the duration doesn't matter as long as you're protecting kids at particular key moments in their lives. So the reactogenicity, another bunch of histograms, but if you look at the bottom right-hand corner, it's that fever response greater than 38.5 that sort of raised flags, because it's a bit of a problem if you're going to immunize infants and then they're all going to go to the emergency room, because that factors into cost effectiveness and stuff. I'm going to come back to that in a moment. So for adolescents, which is a different schedule, 2 doses at least a month apart. I'm going to say a month apart. And by the time you get to be adolescents, your immune response is brilliant, and there isn't that much of a drop-off. And so this does work very, very well immunogenicity-wise in the adolescent age group. And this is the persistence, although it's only up to 2 years, was actually pretty good as well, if you look at those red bars. So much more immunogenic with better duration of response, it's assumed, in the adolescent age group. So as I said before, when you introduce a new vaccine, you absolutely have to prove it doesn't interfere with any of the other responses, and the answer is it didn't, apart from that one question mark about polio type 2. But you're talking about a lot of antibody versus a very lot of antibody. So it's not as if anybody thinks that's going to be a clinically significant difference. So back to the fever story, sort of 40 to 50% of these infants receiving the Men B vaccine had a fever greater than 38.0. And so the question is, well, is that significant in real life? And I know that Mark, up next from Quebec, is going to talk about that in the Quebec studies. And so what was noticed here in the pre-licensure studies has not been borne out by experience in Quebec. And so to ameliorate that and to look at it a bit more closely, it was pointed out that if you were in a blinded study, so you didn't know whether your kid got the MenB vaccine or not, you were much more likely to attend either a physician or an emergency room with the fever because you just didn't know what was going on. But in that lower line, in the open label study, where you knew that your child had the MenB vaccine, you were told that fever was likely, and you were giving the Tylenol, there was no difference between the routine vaccine rate of medical attendance and getting the vaccine. And so it's one of those, anxiety things about your child with fever, that if you were told that the MenB vaccine was likely to give fever and you gave some Tylenol, you were just as likely to have to go to the emergency room as if your child had not had the MenB vaccine. And so I think that was very, very reassuring. This slide is just to show that Tylenol does help. So the Health Canada approved schedules are if you start at 2 months, 3 doses followed by a booster after 12 months of age. If you're over 6 months before you start, then it's 2 doses. And so that's quite a complicated schedule, and so that's an important bit of information to have in front of you. And then for adolescents, it's 2 doses at least a month apart. I've talked about that. This is interesting. And so this is the parents of a 5-month-old. The grandparent may be in the room at the moment who told me this story. So this child, the parents wanted to give the 4-component MenB vaccine, many because they're about to go to New Zealand, which still has a higher rate of MenB disease than most places. So they were unable to make the appointment, first of all, to go and see the family doctor before travel, so that didn't happen. Could not get it from the health unit, because the health unit did not have it. And we're going to say things to public health later this morning about why the heck is that. After the travel, mum goes to the family doctor and says, I want a prescription for this MenB vaccine. She took the prescription to the pharmacy. The pharmacy said, well, actually, the family doctor's written the wrong prescription. He's written it for the quadrivalent vaccine, and it's not approved for children before 6 months of age. Mum has to go back to the GP and say, actually, it was the MenB vaccine I wanted. It is called Bexsero. And so the family doctor says, oh. And he again wrote the script for the wrong vaccine. And so finally, with the right prescription in hand, the family doctor, prompted by the parent to look it up, even though the family doctor said, oh, well, MenB, that's not really a problem in Canada. Why would you want your child to have that? And so all of this just speaks to how much education is required for new vaccines that are not in public programs, where the public health people are not doing that whole education piece for you. So the GP looked it up, wrote the right prescription. Mum took it to the pharmacy, came back 2 days later. I've calculated, this whole story involved 7 trips to the GP and 7 trips to the pharmacist. This is not easy. You've got to be really dedicated with your grandparent prodding you in the back to get this done. So the pharmacy charged $221 for the single dose. The list price is about $100 with, whatever your pharmacy markup is. The vaccine got stored in the parents' fridge, and it was a week later that there was enough time to go back to the family doctor to actually give the vaccine. And so there's a whole cold chain thing involved there. How cold is your fridge? Is it too cold, or is it just the right temperature for the vaccine to be stable. So that's a problem. Grandparent points out, you've been charged too much. Parent goes back to pharmacy thinking that the pharmacy must have thought that this was the 2-dose schedule and had charged all the money up front for the first dose. Anyway, money gets returned to parent. Call later, when the second dose is due, call the pharmacy, say, that prescription I brought in, I'm going to go back for the second dose. Pharmacist says, sorry, only 1 dose was put on the prescription. And so this time Dad has taken over. He goes back to the GP, says, can I have a prescription for the second dose? Dad takes the prescription to the pharmacy. The pharmacy gets it wrong this time and says, oh, here's the quadrivalent vaccine. Dad, who's sort of wise to this, says, no, that's wrong. And so the mum has to call the family doctor's office again, who the GP said, no, you only need 1 dose, you don't need 2 doses. That's completely wrong. Mum goes to the family doctor's office, hits him over the head with the product monograph, and the family doctor says, oh, all right, gives another prescription for a single dose. Again, the same palaver about the cooler, bring it back to the fridge. Pharmacist does charge the right amount this time. And again, there's a delay of a week before the vaccine's given. So the good news about all this is actually the kid was absolutely fine with the vaccine. Put a bit of freezing stuff on the skin beforehand, which you can almost never dissuade parents from doing. No fever was noticed at all, no local reactions, a little bit fussy, but that was it. So actually, for this particular kid, the vaccine was well tolerated. But for heaven's sake, why do you have to go through all of those steps in order to give what should be a fairly simple vaccine? So we're going to stick it to, Monica and Tamsin later as to why on earth, and pharmacy, as to, why on earth is this such a palaver to get a vaccine just because it's not in public programs, but it is licensed and you should be able to get it. So I've talked about this. And so, to go back to that other bits of the framework, so that there are opportunity costs to the family, like all of this delays to actually, go get the vaccine is very expensive to families. It's probably expensive to the health system as well. I mean, I'm not sure how much sort of wastage is involved in trying to bring in a non-licensed vaccine, have it in your pharmacy fridge, and then not actually have it used. And then, cost benefit is a very complicated business, and I'll talk about the British experience if I've got time. The public perception is that this is a very severe disease, and they would like their child protected. And I'm just going to hopefully got something by Bill Fisher somewhere here. So Bill Fisher did a lot of work in terms of how acceptable and at what price would a meningococcal B vaccine be accepted by the public. And even at quite a high price, most people, when it's discussed with them about how severe the disease is, say that they would like their child protected. I do a whole other talk about the cost of infant vaccines, where a couple of slides later I point out that this enormous cost of first-year vaccines is actually what the Canadian public will spend on their puppies to get a dog immunised. Without any question, they'll spend hundreds of dollars immunising their puppy in the first year of life. But if you present it correctly to parents, they're also prepared to pay money for their infant. So the JCVI in the UK looked at Men B vaccine and said, well, like NACI, no way are we spending money on this. But then they redid the numbers by taking one of their doses of Men C vaccine out, based on Julie's work, and by transferring the cost of that dose of Men C vaccine to a Men B program, they reckon it is cost effective. And so the plan, I think, is for the UK to introduce a program, but there are convoluted negotiations going on with the manufacturer as to the price at which that will be offered. and about that, we're not supposed to know any more. So what's interesting is that the UK media did not take kindly to the committee saying that they were not going to use the vaccine. And that's a very important point. Like the public perception about not having the vaccine available went down very badly in the UK. And we haven't seen that in Canada, but in whichever jurisdiction, you only need 1 or 2 cases of invasive meningococcal B disease, and there was one in the paper last week from Halifax, before, parents do not take kindly to their child either dying or being left handicapped for a disease that is vaccine preventable. And so this is a very politically sensitive disease. So the NACI statement says, given all the uncertainty around forced CMNB vaccine, it is recommended that the vaccine not be used unless a comprehensive plan is implemented to evaluate its impact through surveillance and research as a prerequisite to implementation. And hopefully that's a good lead-in to Mark from Quebec, who hopefully answer that question. Thank you.
Thank you, Simon, for such a comprehensive overview of the whole topic of immunization with respect to this. I shouldn't say a whole overview because there's more to come, but certainly very comprehensive, some of the difficulties with this specific disease and immunizing against it. We really are lucky to have Marc Lebel here to talk to us today. Marc's a specialist in pediatric infectious disease at the CHU in Saint-Justine at the University of Montreal. And he did his residency in pediatrics there and fellowship in Peds ID in Texas and Dallas, as well as medical microbiology in Montreal. Now, Marc's worked extensively with respect to meningitis and immune response, but also has been very involved in real world research in terms of the epidemiology and the especially in Quebec, and has been leading the use of the 4-CMNB vaccine in Quebec, and probably, as said earlier, it's probably one of the largest use of this vaccine anywhere in the world at this stage. And can't say they're fortunate to have an outbreak because that would be untrue, but their epidemiology is such that they've had opportunity to use this vaccine, and certainly look forward to hearing his experience, especially with respect to the adverse effects, which certainly in some of the initial research suggested that they'd be quite problematic, and I'm really looking forward to hearing Marc talk about this today. Thanks, Marc, for joining us. Sorry. Hopefully we'll have you up here on the main screen.
Your mic is still muted.
Yeah,
we cannot hear you yet. Your mic is muted. Nope, not yet. Do you have a remote that you can unmute your mic? Nope, not yet. Nope, not yet. Is a touch panel in the room or is it remote control? Let me check something.
If we could get you on the big screen, if you knew sign language, maybe.
Let's try one more time.
Can you try again, Marc? We may be.
Here?
Yep, perfect. Thanks, Marc. Gotcha.
You do? Okay, sorry for that.
Yeah, one second. So, I'm going to release, give me 1 second. I'm going to release the 4 for you. 1 sec.
That's fine? So just tell me when that's fine.
Can you send the PowerPoint one more time right now?
Yes. Do you see it?
Yeah, we only can see your PowerPoint, but not you right now. I guess only the option, right?
That's the only option, either me or
Okay.
the
Okay, no problem. Then we will see the PowerPoint, and then after you do your presentation, we can switch it back for Q&A. Thanks.
Thank you very much for having me the opportunity to discuss with you the Quebec experience. Just say it's sunny in Montreal, but there was minus 22 this morning. So in Quebec, these are my disclosure, and we certainly have had a very particular and very different epidemiology of MenB disease. So what I wanted to discuss with you is basically the safety profile of the vaccines. I know that Julie already had spoken to you about the epidemiology in Canada. This is a representation of certain areas of Quebec province from 2006 to 2013. And what you see in blue is the Saguenay-Lac-Saint-Jean area, where they've been having a higher rate of meningococcal disease for the past 7 to 10 years. The dashed line is Montreal area, and the blue line is the Saguenay-Lac-Saint-Jean. Most of the time they were in a range of 10 to 20 per 100,000. I think this picture will show certainly much more the difference between the Saguenay and the rest of the province. So the Saguenay in that chart is in red. So you can see for children less than 1 year of age, the incidence was about 38 per 100,000, and it was much higher in very young children, and after that in adolescents. So the rates were way, way, way higher in that area, and there was a sustained rate over a 7 to 8 year period. From the clinical studies that enroll about 8,000 patients, we already had some data looking at local side effect and systemic side effect. And because of the nature of the vaccine and the OMV portion of that vaccine, we know that this vaccine will cause effectively more local and more systemic side effect. In that figure, you can see in the upper portion, you have the 4CMB, so the MenB vaccine plus routine vaccination at 2 for 6 months versus the MenC vaccine plus routine immunization. And you can see from the chart that effectively there was more tenderness, erythema, induration, and swelling. In fact, lots of people in public health had lots of questions about the reactogenicity of the vaccine. The other particularity of that vaccine was the higher incidence of fever, especially the peak was around 6 hours after the vaccine. The first studies were done without any fever prophylaxis, so without acetaminophen, and subsequent studies evaluated the impact of acetaminophen, in fact, on the fever rate. And from the chart, it really shows that the incidence of fever is really decreased by the use of prophylactic acetaminophen. So that's what we knew from the clinical studies. After that, there have been outbreaks in several universities in the U.S., and there's been two big immunization programs, one at the University of California in Santa Barbara and the other one in Princeton, where they immunize close to 7,000 students in the first university, and the second one close to 5,000 students. And there was a study that was done by the FDA. At that time, the vaccine was not approved in the U.S., and basically that showed that there was no unusual patterns of serious reaction with the vaccine, and it was in the older adolescents and adults. In Quebec province, there was lots of discussion last year about targeted program for the Saguenay-Lac-Saint-Jean. Finally, the decision was made in the beginning of last year, and the program ran, in fact, from May last year, and it's still ongoing right now. Who we targeted were children from 2 months to 20 years of age, either the ones that were residing in the Saguenay-Lac-Saint-Jean or the ones who were attending the region. So the immunization program ran into 2 waves. The first one was from May 5th to June 17, and the second one was from fall, from September to December, January. Just to say there was a huge process, especially for public health, where they immunized close to 45,000 infants, children, and adolescents in a 6-week period. So, and just to put in perspective, this is the largest experience with the MenB vaccine worldwide. Public health, as I mentioned, was very interested about the potential of side effects. So there was both passive surveillance as usual for side effects, but also there was an active surveillance program. So this, they evaluated close to 44,000 vaccinees. They asked for their email address, and from the big number, about 28% completed the questionnaire, so that look effectively at the side effect. And we have, so for the surveillance, we have both an active and a passive surveillance. And looking at that, so close to 1/4 of the infant, children, and adolescents were surveyed in the side effect profile, and you have a representation of all the age group. This slide is in French, but I think that probably what is most important is to see this is children from 2 months to 20 years, and to see how many receive at least 1 dose. This was at the beginning of September. So overall, 80% of children had received at that time at least 1 dose. 80% is in fact not distributed equally. When you look at the infants, children, and early adolescents, that's close to 90% of the children who received the vaccine. One thing that was, in fact, not very good is in the 17 to 20 years of age group, less than half received the vaccine, and probably has to go with the fact that they think they're immune to it. But when we were looking at the epidemiology, we have to remember that the ones who were most affected were very young children and adolescents. And despite lots of effort from public health, we're still around at 50% in the 17 to 20 years of age group. So the first thing that was really looked at was the incidence of fever. The incidence of fever, if we recall the first studies that did not use acetaminophen at all, the incidence of fever was 40 to 60%. In the program, parents were told to give acetaminophen for the first 10 to 12 hours, so right after vaccination and every 4 to 6 hours after. And this is the distribution of fever according to age. So the youngest ones effectively had a higher rate of fever, but we're much more in the range of 10 to 12%, which is much less. And this is basically because of the use of acetaminophen. When you arrive in the older age group, the incidence of fever can decrease. In fact, the fever was more prevalent in the first and second days after the vaccination. This is a chart looking at the prevalence of fever. So mainly the first 2 days after vaccination, and much more in the younger age group, but certainly way much less than without acetaminophen prophylaxis. So the one thing that was looked at was the number of acetaminophen doses. So those who were not reporting using acetaminophen had a higher rate of fever compared to those who reported having used acetaminophen. Incidence is higher, especially in the 2 to 11 months of age, less than in the 1 to 2 years of age, and progressively as age goes up, the incidence of fever goes down. And when you arrive at children 11 to 20 years, the incidence of fever is in fact relatively low. In the program, there was recommended to give acetaminophen prophylaxis in children less than 2 years of age, to give it routinely. For older children, there was depending effectively if there was fever or not. So there's lots of potential side effects that were looked at. And in fact, there was lots of fears by public health that with that vaccine, there would be lots of medical consultation, lots of septic workup, lots of lumbar puncture, but in fact, this did not happen. The hospitalization rate was less than 1%. One thing that probably really stand out, and we'll discuss more after, is the absenteeism or medical consultation. The overall is about 6% of that cohort, and it varies from one to the other. And just to realize that not going to school or daycare can affect the one who's immunized, but can affect effectively the caregiver. So this is the proportion according to age. When you look more at the type of reaction for which at one point they either sought medical consultation in the first 7 days or did not go to daycare and school, what you can see that most of them could be either local reaction or general malaise, not doing fine. There's some at one point that could be respiratory problem, GI problem. The thing with that at one point, it's not necessarily related to the vaccine. When you look at the adolescents and young adults, there was a higher proportion of in that age group of either absenteeism, and that very often was either for local reaction or general malaise. But one thing you have to remember in the studies that were done with the 4CMB vaccine, when you were looking at side effects in adolescents, they had quite a very high percentage even in the placebo groups. I think it's more a relation to the age group rather than just the vaccine. So again, if we look at the big cohort, 43,000 immunized, 28%, 12,000 completed the questionnaire. About 10-11% reported fever, 6% did not go to daycare or school, and 1.2% had medical consultation. Febrile seizures was very, very looked at. In fact, they asked the pediatrician to describe about anything that was going on after vaccination. And there was 2 cases of febrile seizure, one that was in the passive surveillance, the other one in the active surveillance. Just from the clinical studies that were done and the number of children immunized, we thought that we would have about 6 cases of febrile seizure, so we certainly did not have more than what was expected. There was also question in the clinical studies about Kawasaki's disease. In that study, there was no case of Kawasaki's detected. Now, on the other hand, the number is relatively slow. The cohort is relatively slow. The other thing that was looked at was arthralgias. In one of the studies, there was as high as 12% in the 40 to 43 months age group. And looking at the full cohort, it was 113 cases of arthralgias. Lots of them were not even clear there was really arthralgia, but that represent less than 1% of vaccinees. So again, very well tolerated. At this point, there's more than 90,000 doses have been administered in Saguenay-Lac-Saint-Jean, both in the first wave and the second wave. The percentage of children receiving their second dose is pretty much looked effectively like what it looked after the first dose. The repartition is about the same. The 17 to 20 year of age is still not very good. That still range between 40 to 50% of them have been immunized, and that's probably one of the difficulties of the program is reaching the adolescents. Overall, the vaccine, in fact, has been very well tolerated. This vaccine effectively gives more local side effects, but at one point people have to remember the time where we were using cellular pertussis vaccine that gave more effectively local reaction. I think once parents are notified or the adolescent is notified about that, I think that's very good. In fact, they asked after the first wave, they did a study asking the parents or the child or the adolescent whether or not they were planning to receive the second dose, and more than 90% of them said that they would receive the second dose regardless that they had or not local or systemic side effect. Acetaminophen prophylaxis in clinical practice in Saguenay-Lac-Saint-Jean certainly had a big impact with reduction of fever, and that's fever rates are way much lower than without acetaminophen. That should be encouraged. In the program, we recommended to have acetaminophen prophylaxis in the 2 months to 2 years of age. There was no specific recommendation about giving it routinely from the 2 to 11 years of age. When you look at the chart, the fever chart, for the older children up until 11 years of age, that's something that could be at least discussed with the parents. The good thing about the program, as I mentioned, we're close to 90,000 doses. There was no severe or no unexpected side effects. If you add that with the experience of Princeton and Santa Barbara, then you have a much higher number. And as I mentioned, the last effectively slide was effectively there's no, even if they have side effect, that does not have an impact on the intent to have the second dose. Thank you. You should thank me now.
We've got you there. We can see you.
Okay.
Absolutely. Thank you very much, Mark. I'm going to start off. I'm just curious, is this a one-time program or is this continuing?
The program, as I mentioned, it was lots and lots and lots of discussions. At this point, the program is one time, so that's children. That's up until children born on December 31st. The number of cases they have normally in the Saguenay-Lac-Saint-Jean is about 15 cases a year, which is about the same as Saint-Justin, which is tertiary care center. And the good thing is that since they started the meningococcal program, MenB program, in May, they have had 0 cases so far. So I think that will be interesting to know what's happening during winter and springtime, where generally you have more cases. When we did the MenC program in 2001, we had a massive immunization program, 2.2 million infants and children and adolescents that were immunized, and we stopped in May. I'm going back in 2001. Then we restarted a program in September. At this point, there's no decision that have been made to decide to continue.
And I'm just going to ask one more question before Simon has a question. Oh, no, he's waving off. He doesn't have questions. He knows everything. So I'm just curious, are you looking into colonization at all?
The program went so fast that we didn't have time to do that. At this point, the emphasis was more on side effects and tolerance of the vaccine. So sadly, because basically between the time, and there was an election time when we made the decision, between the time that the Quebec Immunization Committee recommended the vaccine and the time we started, I think there was less than 1 month. So that's very, very fast. I must say Public Health did an outstanding job to be able to immunize about 45,000 kids in 6 weeks. That's pretty good.
That is impressive. So any questions from the audience? I think that's it, Mark. We really appreciated that. Thank you very, very much for taking some of your time on a cold Saturday in Montreal to come and join us.
Sunny.
Sunny? Excellent.
Thank you.
Fantastic. Take care.
Bye.
So, bye-bye. So I think we'll take a refreshment break for now and maybe come back in about 15 minutes. And we can always round you up earlier if we decide we're bored. Let's see, we have Nanaimo still, great, and we got Royal Columbian, which is fantastic. I'd like to introduce Monica Naus, who's going to talk to us about provincial decision-making, which she certainly has a lot of information about. She's communicable disease control. She's with BC CDC since 2001 and medical director of the Immunization Program and Vaccine Preventable Disease Center at the BC CDC. She's also associate professor in the School of Population Public Health, UBC, and she was a member of NACI for 12 years, which is extraordinary, as well as chairwoman for 4 of these years. And so she has an incredible knowledge of how these vaccines get licensed and put on the schedules, and we're very fortunate to have Monica today. Thank you very much for coming.
Thank you. Thank you very much. My time on NACI was up to the statute of limitations because 12 years is their maximum stint time. And I've been involved in immunization programs since the start of my career in public health, both in Ontario and British Columbia. And the processes in those 2 jurisdictions are very similar. I've updated my slide set this morning because of some of the items that Julie's covered and Simon as well. And I'll be faster over some slides than others because Simon's discussed the process to some extent around how decisions are made about putting vaccines into publicly funded immunization schedules. I have no affiliations with commercial or other industry interest, I guess, apart from eating today's breakfast and lunch. And the objectives that I was provided with for my session are to describe the processes by which vaccines are recommended for public funding in BC, to go over how we've introduced and the current status of meningococcal vaccine programs in BC with regards to future decision-making around expansions. And I will touch briefly on the provincial policy about the role of public health providers in purchasable but not publicly funded vaccines. And I think Tamsin was given that same objective and will be covering that as well. So vaccines are regulated, even though I find Canadians saying FDA as though it was a Canadian institution. In fact, our regulator is Health Canada. And when they approve a product for use, they have specific indications for use, and those typically include age indications, as well as indications for prevention of specific outcomes. And once it's known that a product is in the approvals pipeline with the regulator, even though that's largely an in-camera process and there's not a lot of detail provided, which is very different, for example, than the American process, which is very transparent. Health Canada, through the National Advisory Committee on Immunization, undertakes a process of planning to issue a statement. And a recent change in Canada has been a commitment by NACI to have a statement shortly after the approval date of a vaccine product. Sometimes they're caught off guard if, for example, a product may be on a short track, on is it 180 days for the short track? Otherwise, it's about a year-long process to go through the approvals at Health Canada. And certainly the industry has clearly stated a preference for a recommendation to be available from NACI within 90 days of a product approval. And NACI has been aiming for that. Simon alluded to a new process whereby NACI has teamed up with the Canadian Immunization Committee to develop a statement that looks at more than just vaccine characteristics and burden of illness. And the traditional NACI statement is simply a review of the epidemiology of the disease in Canada, as well as information about the vaccine, its immunogenicity, what's known about efficacy or effectiveness. If it's been used in other countries, there may be effectiveness data, as well as safety. But NACI doesn't take a look at other aspects of vaccine use, including health economic analyses or the logistics of rolling out a program. For example, they may comment, but they wouldn't do a comprehensive analysis on something like the feasibility of managing freezer storage for zoster vaccine in Canada. That's been the task of the Canadian Immunization Committee, and the meningococcal B vaccine is the first example where there was an attempt to develop a comprehensive statement, which was called a common guidance document. And so the statement posted on the NACI website is the first such statement that looks at that whole spectrum. But none of these recommendations are necessarily determine the outcome at a provincial territorial level, even though I think that NACI recommendations are regarded very highly by provinces and territories, and many are guided probably exclusively by NACI recommendations because they may not have the resources in place to do any detailed analysis of the science or the economics or the feasibility themselves. And so it is up to, this is under the British North America Act of 1867, where health is a provincial responsibility. And so ultimately, it's up to each Ministry of Health to determine whether and how to incorporate a vaccine program. And one of the things that happens in the discussions around implementation is looking at the feasibility of rolling it out. And that's the reason why you have different grades targeted around Canada for the adolescent meningococcal vaccine, because our education systems aren't all structured the same way. And in some jurisdictions, it's easier to do immunization clinics in schools at different ages. And then once there's a publicly funded program, there's a decision around a publicly funded program, there's program planning and implementation at the jurisdictional level. And in British Columbia, we have a mixed model. About half of young children are vaccinated by primary care physicians, the other half by public health nurses, and that varies at a regional level, so that most of our physician immunization goes on in urban centers, and outside of those areas, it's public health. But all of the school-based vaccination is conducted by public health. Simon's already showed you this slide, which is the analytic framework for vaccine programs in Canada. It's a framework that's based on basically a survey that was done at that time of provincial territorial programs to understand what considerations they consider salient in making a decision about introducing a vaccine program. And around this time, there was funding also from the federal government for 2 3-year periods for a total of 6 years in order to bring into publicly funded programs several different recently approved vaccines in order to speed up the process of their introduction into publicly funded programs. And that process has now ended, and health, all of the provinces and territories are now paying for those introduced vaccines. Meningococcal C was one of those vaccines, so was pneumococcal conjugate, acellular pertussis for adolescents, and also varicella for children, as well as HPV for girls. The NACI recommendations for meningococcal conjugate C and quadrivalent programs are summarized on this slide. So NACI does recommend the C conjugate vaccine for routine infant vaccination and for children who haven't been vaccinated in infancy and received a booster dose in their toddlerhood. MenC vaccine is recommended. The current NACI recommendations are a little bit vague on whether a child 5 to 11 should be vaccinated with meningococcal C vaccine if they haven't received the vaccine in the past. But NACI does recommend a booster dose of either MenC or quadrivalent vaccine for children around the age of 12, and also recommends young adult vaccination if they haven't been vaccinated in the past. There are recommendations also for booster doses with conjugate vaccine. Those came out of the ACIP initially, and the United States began vaccinating with quadrivalent conjugate vaccine partly because they had a problem with group Y disease. About 40% of their disease was group Y, and partly because they didn't have any approved meningococcal C conjugate vaccines. And so the diphtheria conjugate quadrivalent vaccine was the product available there. And that's where some data has emerged on vaccine effectiveness, and I'll share that with you. Otherwise, with respect to NACI recommendations, the quadrivalent conjugate is recommended only for medically high risk, lab workers, military recruits, and in terms of routine vaccination for adolescents, only if the epidemiology of non-C disease warrants use. Interestingly, our Canadian recommendations for in the 1990s, which guided decisions around widespread vaccination against meningococcal disease in the context of an outbreak, did have a threshold of incidence. But in the NACI recommendations for conjugate quadrivalent vaccine use, there is no threshold provided. So there's not an incidence of, say, group Y disease in adolescents above which one would be guided by the statement to introduce a quadrivalent conjugate program. But that has been done in a number of jurisdictions. NACI also recommends use for close contacts of cases. For group C disease contacts, they recommend C conjugate vaccine, not the quadrivalent conjugate vaccine. And quadrivalent polysaccharide vaccine is really no longer recommended. And in British Columbia, we only provide that product if the conjugate vaccine is contraindicated in an individual who should receive quadrivalent meningococcal vaccine. In British Columbia, we introduced the first dose at 12 months of age, and we did a grade 6 catch-up program at the time. We also did a catch-up through to the end of high school, so that very rapidly children to the end of grade 12 were vaccinated. And in 2005, we added a dose at 2 months of age. So the first dose went in at 1 month. There was a grade 6 catch-up. There was catch-up through high school, and then subsequently a dose was added at 2 months of age, and that was for protection of infants. And at this point in time, we are maintaining the grade 6 dose as a booster because we know that there is waning immunity with these vaccines. That's different than what's done with hepatitis B vaccine, which is no longer offered in grade 6 to children if they've completed a previous series of hepatitis B vaccine, including in infancy. And then our program for the quadrivalent vaccine is really limited to high-risk individuals. And I've mentioned those. Those are people with medical high-risk conditions. And quadrivalent conjugate vaccine is available for that purpose. The guidelines for vaccine use are in the immunization manual, which is available on our website. And the vaccine-specific guidance is contained in Section 7, Biological Products. And this is the immunization schedule for children all the way to adolescents in British Columbia. So in the hot pink, you see where we give meningococcal conjugate C. So that's at 2 months, at 12 months, and in grade 6. We purchase our vaccine through a federally coordinated bulk purchasing process, and we've made a conscious decision with our infant program since the introduction of the 2-month dose to use only the tetanus toxoid conjugate vaccine. And so on occasion, we've had to purchase it on a sole source basis. And that's through a process that requires us to first state why we intend to sole source it in order to have a justified sole source. And our justification is based on the immunogenicity of these vaccines. And there are a couple of studies from the UK that have looked at this, including one that looked at the diphtheria CRIM conjugate vaccine. And these weren't head-to-head studies, but 56% of those infants had protective antibody after a single dose of that vaccine, compared to 100% of infants in a different study achieving protective antibody after 1 dose. And there has been a study also conducted in the UK among toddlers. So this is a vaccine given not in infancy, but in the 2nd year of life. The mean age of recipients in these studies was 13.6 months, and they were boosted with polysaccharide vaccine as a test of priming with the conjugate vaccine. And that's, of course, the important differentiation with the conjugate vaccines. And you can see that in the 3 groups with the 3rd column and the circled information applying to the tetanus toxoid conjugate vaccine, which is the one that we use in the infant program in British Columbia, both the GMTs were substantially higher, and after the polysaccharide vaccine booster dose, there was also higher GMT responses and seroconversion rates. So this is a more immunogenic product, and if you're going to be using an off-label schedule as we do in infancy, because we don't administer 3 doses, we only administer 2 doses, there is a differential benefit, at least based on these data, in using a vaccine that generates a higher level of protection. Simon's already talked about the importance of having bactericidal antibody around at the time that the exposure occurs. With this disease, you don't have the same time as you do with hepatitis B infection to mount an anamnestic response because the incubation period is so much shorter. And Julie Bettinger, our very own British Columbia researcher, has also looked at the differential immune response and this is all the same vaccine now, the tetanus toxoid conjugate vaccine, in 3 different provinces that use 3 different schedules. So in British Columbia, we have a 2 and 12 month schedule. Alberta has 2, 4, and 12 months. They've got the oil money. And Nova Scotia has just a 12-month dose, which is what we started. Like our schedules. I know, they had the oil money. In that study, what was done was to bleed infants prior to their 12-month dose. So in Nova Scotia, those are children who wouldn't have received any previous doses of meningococcal vaccine. In Alberta, they would have received 2 previous doses, and in British Columbia, they would have received 1 at 2 months of age. And the results were that for the British Columbia infants, 84% had bactericidal antibody at or above 1 in 8, which is considered protective. In Alberta, 100% did, and in Nova Scotia, 27% did. So we weren't at 100%, but we've had no cases in infants under this schedule in British Columbia. And in fact, we haven't had any cases in children since 2008 in British Columbia. So since 2009 onwards, we've had no pediatric or young adult cases of meningococcal C. This slide shows our uptake, and it's interesting that Quebec has found low uptake in adolescents, even in the context of hyper-endemic meningococcal B disease. We offer this vaccine at grade 6, and I think in general we find the same thing, that at grade 9 the uptakes are lower, than they are in grade 6. That's been a trend with HPV, for instance. And so our base programs run in grade 6, where we still have parental consent. The forms tend to come back, and we have better uptake rates. And meningococcal B uptake is around 90%, and that's those are the provincial rates. Julie's also already shown you this slide, and I just want to put it up again because it's a real success story for Group C disease, with no cases of Group C at all in 2011, and then sporadic cases only in adults since 2008. So none of those cases that you see after 2008 are occurring in children or young adults. And what bounces around and the driver of current discussions at the Ministry of Health and at our Communicable Disease Policy Advisory Committee, which is the group that makes the recommendations to the ministry, is the discussion around Group Y disease. That's a disease, the maximal number of cases in any given year that we've had reported is 10. The least is 1. And it basically bounces around within that range from 1 to 10 cases a year, about 5 on average. And that's what you see in the recent years in British Columbia, 4, 5, and 5 cases. But of the 8 cases that have been fatal, and this is the case fatality rate in British Columbia over a 14-year period by serogroup, our Group C case fatality rate 21.4%, so similar, I think, to the findings from the impact data, which are based on hospitalized children. Our Group Y case fatality 10.8%, and so those are 8 deaths in 14 years out of 74 cases. Half of those cases and half of those deaths are in young individuals, and half of the deaths are in 15 to 24-year-olds. The other half of the deaths, so the other 4 deaths, are in individuals over 40 years of age. So we've had 4 young people die in 14 years due to Group Y disease, and I guess 3 of those individuals are parents who've become very strong advocates for conjugate quadrivalent meningococcal vaccine, and I've had conversations with 2 of those parents myself. And on this slide, what I really want you to see is that there's a wide age range for cases, so everything from infancy to very old individuals, and Julie highlighted that in her presentation as well. And the important finding is that since we started vaccinating, our median age of serogroup C cases, which is the only group that we've affected by vaccination, has declined from 24 years before we started vaccinating to 36 years during the first few years of our vaccination program. And in the last 5 years, the median age of serogroup C cases is 66.5. So we've completely shifted the age distribution of meningococcal C disease. But at the same time, we have dropped rates across the age span, which is evidence of the impact of reduction of nasopharyngeal carriage. And for Group Y disease, this is just a picture of the cases of Group Y in individuals under 25, as well as those 25 and older. So in the green bars are the young individuals, in the blue bar, the 25 and older, and then the crosshatches show the cases that have been fatal. So we did have a cluster of 4 fatalities. So out of 8 deaths over this entire 14-year period, 4 of those deaths occurred in 2011 and 2012. And 2 of those deaths were young adults, both at universities, 1 in Victoria and 1 in the interior. And we had a lot of advocacy and a lot of interest by university and college programs in offering meningococcal conjugate vaccine to their enrollees at that time. So meningococcal conjugate quadrivalent vaccine, 6 provinces in the country have programs in grades 4 through grade 9. So each province has a program targeting only a single grade, but it ranges from grade 4 to grade 9. The largest province with the program is Ontario, and I've been asking them on a regular basis about whether they got evidence in their data of a decline in Group Y disease as a result of introducing this vaccine, and they're not confident they can say that yet at this point in time, but that's obviously of interest for us. In British Columbia, we use the conjugate vaccine for high-risk individuals, and there are 3 products approved for use in Canada that are conjugate quadrivalent products. Only one of those is recommended and approved for use as early as 2 months of age. Laura flagged for me that NACI and Health Canada both have indications for using that down to 2 months of age. Initially, it was an off-label recommendation by NACI, but the December product monograph change has resulted in a Health Canada approval of that young age of use as well. In British Columbia, we have recommended through our Communicable Disease Policy Advisory Committee a quadrivalent program for adolescents, and that would pick up the Group Y. What's not clear is what the best age to give that vaccine is, because all of our fatal cases are in that 15 to 24-year age group, and because the duration of protection of these vaccines is not lifelong, it may be better to place that in grade 9 rather than grade 6. And one thing that we don't want to happen, of course, is to lose any protection from Group C, because that grade 6 dose for Group C right now is currently intended to pick up where the early childhood vaccine left off. This is a publication from the United States, and the only one that I'm aware of that's looked at the effectiveness of quadrivalent conjugate vaccines. The United States introduced the diphtheria conjugate vaccine, so that's Menactra, and this is a case series of 14 cases of vaccine failures. So here they're called breakthrough cases, but this is invasive meningococcal disease among vaccinated individuals. And the authors calculated vaccine effectiveness against C and Y based on these data as somewhere between 80 and 85%, which is substantially less than the vaccine effectiveness against Group C observed in the UK, which has been at 96%. And I think that was a surprise. And the duration of protection of the quadrivalent vaccines is uncertain. This study did not examine duration of protection, and the duration of protection information really comes from immunogenicity data right now, which do indicate that there's waning of immunity. So by about 5 years, there's not a lot of protection based on serum bactericidal antibody. And that's the discussion about where do you best place this dose if you're trying to protect younger children against Group C, but you're really trying to prevent deaths from Group Y among older individuals. In terms of private purchase of vaccines, there's a variety of vaccines that are not publicly funded. And I think with meningococcal B vaccine, the issue there is that it's not recommended by NACI for routine infant use at this time. And so I don't believe that a lot of provincial and territorial policy committees are necessarily spending a lot of time considering meningococcal B, but I think it will continue to stay on our radar, obviously. And for quadrivalent conjugate vaccine, that's a vaccine that's not been publicly funded in British Columbia because of the rarity of this disease and the lack of cost effectiveness that results from the rarity. But we do have a policy statement from the British Columbia Immunization Committee that public health does have a role in informing parents or members of the public about vaccines that are recommended for use. So once a vaccine is recommended for use, even if it's not publicly funded, it's very similar to what the Canadian Medical Protective Association advises to physicians, that you should make the individual aware of the availability of the vaccine and the recommendations for its use, regardless of whether you think they can afford to pay for it. And in a family with several children, potentially eligible for, say, 2 doses of meningococcal B vaccine, that can be a large price tag. So this is just the page with the CMPA recommendations, and they're basically what I've outlined right now. We do provide information about non-publicly funded vaccines for children on our website, Immunize BC, and a variety of vaccines have recommendations for use that we may not fund. And so there's a list of those available for parents or anybody to take a look, and information about how to obtain vaccines like that, even though sometimes the logistics are complicated, as Simon has described, and I had the same trying to get a quadrivalent conjugate purchased for my son. This is just my favorite picture from our website of a grandpa and his little boy, who you can tell absolutely adore one another. So in summary, routine vaccination against serogroup C in children has resulted in near elimination of group C disease. We had a Y increase in British Columbia, small numbers, but 2 deaths in adolescents in 2011 and 2012, but it was not a sustained increase. Half of cases and deaths are in the 15 to 24-year age group, and half are older adults. So the discussion is really around the best placement of a conjugate vaccine and whether that might have negative implications for control of group C disease. Meanwhile, there are 3 conjugate vaccines available for purchase in Canada, and the meningococcal B vaccine is publicly funded in British Columbia at this point in time, only for close contacts of cases, but we are working on a program for high-risk individuals, and it's not recommended for routine use at this point in time by the National Advisory Committee or the Canadian Immunization Committee. So thank you very much. Are there any questions?
No, if there are no questions, it's just
We're going to have the discussion.
And we'll have our panel later. So I just think, even though Monica went over time, I just have to say, despite the fact we, for example, don't have quadrivalent routine immunization in BC, I think you'll agree that we're really blessed by the quality of decision making that goes into these decisions, which are not easy and which are incredibly complex, and really appreciated seeing some of the really very detailed issues there. We're lucky to have Tamsin Morgana. She's the regional immunization leader for Vancouver Coastal. She's a member of a number of provincial committees, including one that I sit on, the BC Immunization Committee, and also has developed a number of resources, such as a book called Immunization, Important Choice You Make for Your Child. And she's also been co-author of one of the Immunize BC's tools, the Immunization Communication Tool for Immunizers. And she's going to talk about the health authority role in licensed but unfunded meningococcal vaccines. And I think this is really interesting because certainly when I came to BC, if something wasn't funded for everybody, nobody was getting it, basically. At least now, I was in a very left-wing part of the province at the time, shifted a bit to the north, but I think it's really a credit to BC CDC and the health authorities that we've come up with so many resources for unfunded vaccines that are still recommended, but just for a variety of reasons are not publicly funded. And I'd like to welcome Tamsin to talk to us. Thank you very much.
Give you one person. Thanks again.
Hi, thanks for inviting me to be a part of this morning. It's been some great content. So I have no relationships with commercial interests, and I'm here to talk about the health authority role. And these are the learning objectives, which I Thank you, received. And so our ultimate aim is to protect the public by preventing vaccine-preventable diseases, and we're talking this morning about meningococcal. We provide access to vaccine, we provide support to ensure each patient client receives the right information and recommendations. We keep our community immunizers informed, and we keep the public informed, and I'll talk a little bit about all of those areas. The first thing we do, most importantly, is we provide access, and we provide access to the provincially funded vaccines to our community partners for eligible patients. That includes our physicians, pharmacists, and some private immunizers. Within public health, we offer a spectrum of immunization services across our health authority. We have 18 offices, and I'm speaking of the Vancouver coastal experience. Services are similar but will vary across the province. We offer on-site services and also community services, primarily in the school-based setting. I did want to mention, because we come across this once in a while, that our nurses at this point in time are not immunizing if a client brings a purchased vaccine to public health to receive it. Our policy at this point is to not provide that immunization, and that might vary by health authority. We offer limited private sale vaccines. We have some services, and there's an example, our North Shore and Richmond offices. We have our travel clinic, which provides a full spectrum of vaccines, both free and private sale, and also offers travel medicine advice. And we spend quite a bit of time informing and referring to other access points and our physicians and pharmacists. We provide support to ensure immunization providers recommend the right vaccines. We spend a lot of time doing this. We educate and inform about the vaccines and schedule recommendations. We do this through our MHO services. We have nursing on call lines. There should be someone available at all times. We provide general assistance, and then we also provide recommendations on complex histories. And as Monica spoke before, the BC CDC Immunization Manual is our standard of practice. It doesn't always answer all our questions, so we sometimes go to the Canadian Immunization Guide to see what it says. Sometimes we look at the American guidelines, or we speak with local immunization experts. Just looking at the spectrum of meningococcal vaccines that are provided by public health, these are the vaccines that are eligible for patients. So we've got meningococcal conjugate C, we have the meningococcal conjugate quadrivalent, Men-B, and polysaccharide with limited use. So who should be immunized? This is basically split up by target group, and as you can see from this illustration here, in public health, we spend most of our time delivering the Men-C vaccine, and private sale vaccines are focused on the quadrivalent and now the Men-B. Looking at meningococcal C conjugate, the Measles-Vac-C is the vaccine of choice and recommended in the infant series. And we've talked about this a little bit, but this is the schedule for the healthy kids. So 1 dose in infancy at 2 months of age, the second dose in the second year of life at 12 months of age, and then an adolescent dose in grade 6. We see the quadrivalent vaccine on histories, and I'll just talk a little bit about those schedules as well, and we also have our high-risk clients. So persons that are at higher risk, we've got a small group of medically high-risk individuals where the vaccine would be provided free, and then for purchase, that would be based on lifestyle and work risks. And looking at the schedule, it really depends what the age is at presentation. There's different product recommendations by age. The schedules vary depending on when the vaccine is started. And then there's a booster program as well. And sometimes we're juggling, had some Men-C and some quadrivalent, and looking at what the next recommendations are. Looking at Men B, there is just 2 recommendations there for eligibility and public health. We haven't used this vaccine yet. And NACI recommended for private purchase 2 groups there. And then the rest would be for other reasons. Meningococcal quadrivalent polysaccharide, as Monica mentioned, it's rarely used. It's used when there's a contradiction to MenC4 only. We frequently do see this on international records, though. Here's just an example of a record. This one doesn't have polysaccharide on it, but all the combinations I've listed there we have seen. So sometimes we know it's a polysaccharide, sometimes we know it's a conjugate. We see a variety of different combinations, and we assess what's been, what the history is, and then we make recommendations. Most of the time, they haven't received something equivalent to our local program, so we would catch them up for age. We sometimes don't know if it was a conjugate or a polysaccharide. So for these records, the key is if you know if it was a polysaccharide that they received, you want to wait 6 months before you give a conjugate. If you don't know, then wait 6 months. And we are here to help through our on-call lines. If you're challenged at all with these histories, we're there to help you work through it. And I also just wanted to put in a plug for providing your patients with a record, a hard copy record of what you have given them. At this point in time, our systems don't talk together, so please ensure they have a record as well as the documentation in your charts. This is just a snapshot view of some of the histories that we have reviewed and recommendations that we provide based on what age, what their history was, and then what are the next steps. And these are samples from their kindergarten and older program, because we start to see a lot of these for our school-based program, and you are likely seeing some of this in your in the infant program more than we see. I wanted to mention Menvio. We've had a few calls on this where it's a reconstituted vaccine where the A component has been missed. That's the pellet, the powder part of the vaccine. And so when that does happen, the dose does need to be repeated. So another role is keeping our community partners informed. We support physicians' obligations of the CMPA. We also have the same obligations within public health nursing. We do this through a variety of means. We have newsletters, email, health authority website within Vancouver Coastal. It's the Physicians Update. We also have a bag stuffer program where we provide resources when you pick up your vaccine supply. And we talk about the private and publicly funded vaccines. And we also keep the public informed, similar activities. We also have one-to-one counseling and resources, and we maintain online information. And we do handle a lot of calls from the public. I wanted to draw your attention to the BC Health Files. This is our standard for informed consent, and I strongly recommend that you have these in your offices as well, whether you're immunizing or not. They're helpful to give to patients prior to immunization, but also to pass on the information to any of your patients. And I've given you a sample of each of the 3 health files. There's one for meningococcal C, meningococcal quadrivalent, and also now Men B. And there's the link. They can be downloaded. And they're in multiple languages as well. These are some posters we've made. One's targeted to parents, one's targeted to adults, and we adapted these from posters that Fraser Health had made. And I've shared a sample with you. This would be an example of a bag stuffer, and we cover the full spectrum, what a child would be eligible for free, if they're high risk, other vaccines might be eligible for, and then also the ones that are available for private sale. Another resource I've provided you with is a adult quick reference. It's very detailed, but everything's there on one page, and it illustrates healthy adults, what they'd be eligible for, also all the high-risk clients, what vaccines they would be eligible for, and then again at the bottom, the private sale vaccines. This is a book, a parent book. It's available online. I shared with you one of the diagrams in the book. Makes communicating with your families a lot easier when you can show them a picture. You can communicate a lot of information. And this is just the diagram on meningococcal vaccine that's available in the book, that what it prevents against. Our travel clinic does some promotion at peak times, targeted promotion primarily to the 12 to 24 age group. I'm sharing some samples for meningococcal vaccine. And I don't know if you've seen this awareness campaign. I was sharing this with you. This is by Ann Geddes, the photographer that has those beautiful pictures of the babies coming out of flowers. She did an amazing photo display on victims of meningococcal disease. And this was showcased at the Canadian Immunization Conference, and we were able to get right up close to these posters, the originals, and she has just done an amazing job. So just showing you this website if you haven't seen it. So we urge you, please, to recommend all the vaccines, recommend them on time. If you can, stock and offer unfunded vaccines at cost or refer. It's really, really important. The recommendations coming from you are really, really solid recommendations, and they do have a significant impact. And share your personal story. That's really important. You don't have to get into all the analytical data. Just a simple story is very powerful. So our role is to support. That includes all our immunizers, and we're really open to feedback on how we can improve that. And I think we'll probably talk more about that on the panel a bit later. Just share some key websites for you. And that's it.
Thank you very much, Hans. I'm going to ask you some questions when you're on the panel. Okay, so we're going on to family physicians' role in licensed but unfunded vaccines, and we're lucky to have Dr. Claire Young, who initially trained in pharmaceutical sciences and then went to Dublin to UCD, complete her MD. And she's focused on all age groups in her practice, her family practice, and is in the Vancouver Division of Family Practice, and shares a passion with respect to immunization. And we'd certainly interested to hear her view on family physician's role, which is obviously a very important one, since in BC, even though the majority of vaccination is done by public health, certainly some of it is still done by family doctors, and as well, being primary care is a very, very important role in terms of influencing patients' views about what's best for their health. So thank you, Claire.
I'm okay, thanks. So my name is Dr. Claire Young. I'm a family doctor with the Fraser Street Medical Clinic in Vancouver. So I'm going to speak to you today about GP's role in licensed but unfunded meningococcal vaccines. So I have no conflict of interest to declare. The objectives I'm going to aim to cover today are to recognize the GP's role and barriers in non-publicly funded immunizations, and to help identify possible solutions to overcome the barriers that we face to introducing these vaccines in actual clinical practice. So I'm probably going to skip the slide because it's been well covered so far. And I'll start with our first objective, which is to define our role in non-publicly funded vaccines. So first of all, obviously our role is to make sure that we're educated and up to date on these vaccines. And that can happen by a number of different routes. So just reading through the Canadian Family Physician Journal, the BCMJ Journal, the CMA Journal, through CME events, and through networking with other colleagues. So whether that be with pediatricians, other specialists, public health, or pharmacists. And I felt that Simon's story was quite relevant because it's quite hard to remain up to date on all the topics that we get in family practice. And certainly with regards to the meningococcal B vaccine, I was lucky to have heard about it before I was approached about giving this presentation, because we had the Bacero drug rep come to our office. But it wasn't in my latest reading in any of the recent journals. So the type of issues that we want to know about when we learn about these vaccines are we want to know when it's authorized and how long it's been available for. So with the meningococcal B vaccine, it's been available since December 2013. GPs would like to know what kind of research, trials, and NACI recommendations are recommended. And of course, the meningococcal B vaccine is recommended for those at risk, those exposed to close contact, those at risk in outbreak, or wish to be vaccinated. But as emphasized before, it's not yet recommended as routine. Another key thing, obviously, as a GP, if we're going to discuss it with our patients, we want to know the contraindications. So at the moment, from the NACI recommendations, it says anybody with a serious allergy to vaccine components. But there's been no studies so far in pregnant females, lactating females, those who have previously suffered with the invasive meningococcal disease, those under 2 months old or those over 55, and anyone with a chronic medical condition. Side effects are particularly relevant as GPs to make sure we can educate our patients on them. So of course, there's the local side effects of erythema, swelling, pain, and the main systemic side effect being fever, and particularly when given in conjunction with other recommended vaccines. As a GP, we want to know the immunization schedule, and we know that is that for those at least 2 months old. Again, it varies with the age of administration, and it's uncertain at the moment if a booster is required because we're not certain about the duration of protection. We want to know the patient group to focus on and cost. So it's about $100 per dose, and it may be covered by some third-party benefits. Our other role is obviously to educate parents, and how can we do that? So typically this is done in consultations, opportunistically done at what we call RORC visits or baby vaccine checks. Other ways are to provide handouts to parents and through engaging in public health campaigns. Our other role is obviously to work with other healthcare professionals such as pediatricians, nurses, pharmacists, public health, and health authority in promoting these vaccines. So what are our barriers in introducing or promoting non-publicly funded vaccines? I would have to say the biggest barrier is time. These patients are rarely ever booked as a separate consultation to discuss non-publicly funded vaccines. So what typically happens is most GP visits are booked at 10 minutes. Obviously, you need to go through the patient's initial complaint or complaints. And if you have time, if you're lucky at the end of the consultation, you might get a chance to bring up the topic about preventive health and non-publicly funded vaccines. Like I initially said, at baby checkups or RORC visits, those are perfect times to discuss any non-publicly funded vaccines that are recommended. But again, there's multiple topics to cover in one of these visits. So I thought, just out of interest, I know it's pretty small to see, but this is for a 2-month, 4-month, and 6-month RORC checkup. But just so you can see the type of topics that we're meant to cover. So obviously we like to discuss the parents' concerns, spend some time talking about nutrition, spend some time talking about education and safety advice, going through the child's developmental milestones, covering a physical examination, and giving the vaccines on the routine schedule at the very end. So you can see that this is really, really hard to cover in even a 15. Yeah, it's like nearly impossible to cover in 10 minutes. I know at our clinic, most of the female doctors aim to cover this in 15 to 20, but I know lots of GPs that just book their patients at 10 minutes to cover this. Another possible barrier could be billing, because there's no actual additional incentive fee for a GP to discuss non-publicly funded vaccines. Knowledge is a huge barrier, the need to be educated on new and upcoming non-publicly funded vaccines. And the kind of specific barriers I thought about with the meningococcal B vaccine would be perhaps the short time it's available. So some GPs might feel nervous about recommending it, and parents might feel uncertain because of the lack of evidence of long-term effects. There's also insufficient evidence for routine recommendation. Parents are often very nervous about side effects that include fever. And it would be difficult in counseling if we're not quite sure about the protection of the duration or the unknown booster recommendation. So some possible solutions to overcoming the barriers would be to be able to offer a separate consult for educating on these non-publicly funded vaccines. So we can see from the HealthLink handouts that there's actually quite a lot to cover, and you could definitely take up a whole 10-minute consult just on discussing and educating on non-publicly funded vaccines. Providing a billing bonus might incentivize certain GPs to discuss non-publicly funded vaccines. And I think the use of educational resources, so the ones from the HealthLink, the BC Pediatric Society, Immunize BC, if you're able to provide those to parents, particularly at the end of a consultation, to help wrap up that consultation but lead into a recall appointment, would be really helpful. And other solutions include education with other healthcare professionals. So it could be something that we could start introducing to parents, possibly really early stages, such as the early postpartum period, in childcare environments perhaps, at schools, and in lunch and learn sessions. So perhaps getting a group of interested parents together at GP offices with local pharmacy, public health nurse, pediatricians, or health authorities involved. And then, of course, engaging in public health campaigns. So in conclusion, the meningococcal B invasive meningeal disease is serious. It's an important issue on individual and public health levels. The good news is there is a vaccine available. GPs are interested in discussing it, and they have an important role in promotion. But barriers such as lack of time, lack of knowledge need to be overcome. And solutions are possible, particularly in a team approach.
Thank you very much. This is excellent. I've left myself 3 minutes to talk, which is about 2 minutes more than I thought I was going to have to do, but that's okay. So just to introduce myself, I'm Bill Abelson, and let me see if I can figure out how to bring slides up. Okay, to the rescue, fantastic. There we are. And how do I, okay, and I just,
Yeah, forward.
Okay, great.
You want to point something?
Fantastic, we've got it done. So I'm Bill Abelson. I'm a community pediatrician, Prince George. I've got infectious disease training, but I tend to do mostly general pediatric consults. And unfortunately, I have very few conflicts. I wished I had more, but I don't. And I've done some talking sponsored by Merck, Pfizer, Novartis, but not currently in any arrangements with any of them. And trying to recognize community pediatricians' role in educating parents in regard to vaccination and recognizing our role as advocacies, basically, and resources for other healthcare professionals. So what I am is I see patients generally referred to me, and this is the way it works mostly in British Columbia. It doesn't work that way in all provinces. In some provinces, you go to your pediatrician just like you would go to a GP, except that you're a child, so you see a pediatrician for primary care. And in Ontario, for example, chances are they'll give you all your vaccines. And so what I am not is this. I mean, I'm neither silly enough, even in my distractible state, to take down my pants when somebody has a needle behind me, and I'm not the doctor who is going to jab people with the needle either. And so it's kind of an unusual role. I mean, there are some pediatricians in the province who do give vaccines, but in BC, the majority of vaccines are given by public health and primary care and pharmacy. And so it's challenging because I'm not the one, as Claire is, seeing the patient and talking to them about what vaccines. So what our role is, I think, in BC as a pediatrician is more to communicate a positive attitude about vaccination to our patients. When we're seeing somebody for ADHD, I mean, I'm going to ask in the initial consult if their immunizations are up to date, and if they are not, I will certainly try and communicate that they should be brought up to date, and if they're parents who are not keen on immunizations may discuss that, but certainly don't have a discussion with every patient about unfunded vaccines. And so I think in terms of the office, I mean, one approach to that is have the resources in the office, either about the various vaccines. And one thing you'll find that the BC CDC has excellent resources and posters available. And I'd certainly encourage you to look at what's available to put those up. I was intrigued recently. I went to my eye doctor, who certainly has nothing to do with immunization. And, you know, usually they've got beautiful pictures of cornea and retina and all those other things and which drops to use for intraocular pressure. And he had one of the BC CDC Immunize Me type posters up. And I was quite impressed about that. And I think it is very important that consider having those posters up. As well, I think it's important to be an advocate. And it takes all of us to educate, I think, on immunizations, especially the non-publicly funded ones. And I'm always curious about the CMPA recommendations, and you know, you should talk about NACI-funded vaccines. I'm sure everybody in this room, or I suspect most people in this room, because they're here, have read NACI recommendations. But to be blunt, they're not the easiest things to get through. And so if you have if you're specifically in the area and you want to read it in detail because they're pretty impressive documents, it's one thing, but to go out into and sort of suspect that every primary care doctor, every immunizer in this province is going to read that and be able to translate it is probably not realistic. And as well, there are new vaccines all the time, and that's the trick in terms of recommending them. It becomes somewhat overwhelming. And one of the things I've been involved with the BC Pediatric Society, and we're very, I think, very strong advocates of vaccination in particular, but have done a number of projects on non-publicly funded vaccines in conjunction with BC CDC and also sponsored by Novartis, is come up with these schedules. And what I like about them is this is a simpler schedule in 2007 when we started doing this. And on the left-hand side are provincial vaccines, for example, in a slightly different format than was shown by Monica from the website. And on the right side is other vaccines. For example, consider rotavirus vaccine at the time, which wasn't publicly funded at the time. And the nice thing is, sort of going back or going forward to now, is some of these things, even though it looks a bit worrier on the right, it's just the complexity, but actually certain things are now publicly funded. You won't see rotavirus, for example, on the right side. It's now publicly funded. And I think in general, we're fortunate, as I say, that so many good vaccines are funded. I think there are ways to go, and we talk about quadrivalent meningococcal vaccine. Anytime after the age of 2 years. And if you look down here, consider conjugate, either the Menactra, the Menveo, or the Nimenrix instead with a booster dose at the 16 years. We recommend HPV, like the Gardasil, for older girls and women and boys, areas which unfortunately they're still not publicly funded. But the encouraging thing is, I think some of these hopefully will move to the left. But I don't think there will be any shortage of vaccines to fill our spots on the right, because industry is very inventive at coming, and thank goodness, come up with other vaccines to prevent other diseases out there of which there's no shortage. So I think we all have a role to inform. I think we should have resources in our office. I think we should advocate with our health authority. As I say, when I first came up to Prince George over 20 years ago, there was no way public health was giving a vaccine that was not publicly funded, and I think that has changed. It's changed now at Prince George. They still don't do it, but they at least refer you to a travel clinic or somewhere else where they can get them. Other, like Tamsin mentioned at Vancouver Coastal, it sounds like they'll provide products but won't immunize if you bring your own product. So there's a lot of discrepancy, I mean, not just in terms of federally and across the province and the territories, but even in BC, how to get these vaccines. So I'm going to stop talking now and go over to the role of pharmacists in immunization, which I think is really important and somewhat unique to BC. Certainly the various rulings are unique to BC. And I think this is an incredibly important talk because this is a really confusing area. Doctors are kind of like cowboys in a sense. You know, we basically get our license and we can do whatever the hell we want. Pharmacists are way more regulated, and it's good and bad because it's very confusing. And I'm fortunate that Bryce Wong, who's going to be talking to us, who's manager of the Pharmacy Practice Support, the BC Pharmacy Association since 2011, is also a member of BCIC. So I've heard Bryce talk a number of times, and despite the fact that he's very clear and concise and a good speaker, I find this confusing because the rules are somewhat confusing. And so I think this is really important so that we all understand what pharmacists can do at this point in time. Obviously, this may change as legislation changes. And one wonders whether certainly they could be used a bit more aggressively to support the more use of public, like unfunded but available vaccines, which I certainly think is really important because I think ideally we would like our population to be protected against all of these diseases. So thank you, Bryce, for coming up and chatting with us.
Okay, thanks for the introduction, Bill. I don't know if it's a coincidence that you've put the pharmacist between yourselves and lunch, but I'll try to keep this quick. Okay, so like Bill said, I work at the BC Pharmacy Association, and we represent the interests of community pharmacists and pharmacies in the province, and we advocate for their professional role as well as their economic viability. It's been about 6 years since pharmacists have had this authority to administer immunizations, and I think in that time frame we've done a lot of positive things, and so I'll try to highlight some of those things that we've done in the next few slides. I don't have any conflicts to declare, and what I'm hoping that you'll walk away with from this presentation, and I guess the discussion later, is a better understanding of the role of pharmacists in terms of immunizations, and then also pick up on some things that how we could maybe work together to improve uptake of immunizations. So with regards to scope of practice with pharmacists, pharmacists have to successfully complete mandatory training as well as get certified in first aid and CPR in order to apply to get authority to give injections. In terms of who we can inject, we can only inject to those 5 years of age and older. So really our target audience is adolescents and adults. So we're not looking at pediatric vaccines. And then in terms of what we can actually inject, we can only inject immunizations as well as treatment for anaphylaxis. So we're not injecting things like insulin or heparin or things like that. So it's just immunizations. And then from a practical, or I guess a more practice perspective, what kind of vaccines are we actually injecting? We can actually order most publicly funded vaccines and administer them without prescriptions. Obviously, we're not administering or ordering vaccines that are publicly funded that have, pediatric-only indication. And then when it comes to unfunded vaccines, we can purchase pretty much any vaccine. And then where it gets confusing is that we can sell and administer most of them without a prescription, but only if they're recommended by a reputable organization like the CDC. So typically we use the immunization manual. If it's recommended in the immunization manual and unfunded, but unfunded, we can still sell or administer it without a prescription. But if it's not recommended in that immunization manual, then it does require a prescription. So one of the things that I would say, I guess, as prescribers, if you've already seen a client and you've assessed them and you've determined that they need to get a certain vaccine, write a prescription for them. The other reason why you should write a prescription is if the patient has third-party coverage or private insurance, they need a prescriber's prescription in order to cover that. So it'll help prevent situations, I guess, similar to kind of what Simon talked about already about sending the patient, back and forth. So like I said, we're coming on to 6 years of having pharmacists give immunizations, and the number of pharmacists who are authorized to give injections is now over 3,200. And as of 2 years ago, the university introduced immunization training into their curriculum. So now every graduating class of pharmacists also will have that skill when they graduate. And maybe a more telling statistic is the number of pharmacies who actually employ immunizing pharmacists. And we have about 90% of them are employing at least one pharmacist who can give immunization. So that's roughly 1,100 new places for people to get immunizations across the province. So, definitely contributing to improving access and convenience of getting immunization services for the public. So these are some stats from the influenza program, and it's probably the one that pharmacists have had the most experience in contributing to. As you can see, over every year, there's been pretty significant growth in the number of immunizations that pharmacists have been giving. And I think for this past flu season, pharmacists will have given over 420,000 influenza vaccines. So obviously, there's an increasing public awareness about getting their immunizations at the pharmacy and growing acceptance of going to the pharmacy to get those services. And like I said, pharmacists aren't only giving influenza vaccine. No, they are also giving some other publicly funded vaccines, and some of the more notable ones. Pharmacists have given a number of pneumococcal polysaccharide vaccine, usually along with the flu shot. The other program in which they've had a pretty significant role is with the HPV catch-up program. So that's using the bivalent HPV vaccine. Out of any provider group, I think pharmacists have actually administered the most doses of that product. So it really highlights the fact that pharmacists can be effective in terms of targeting the adult population, which has traditionally, I think, been a difficult population to get to from a public health perspective. Some other ways that pharmacists have been used is in terms of outbreak situations. So pharmacists have given a number of Tdap and MMR vaccines during outbreaks in this past couple of years. Now, one of the benefits of having pharmacists come on board with immunizations is obviously that they can sell and administer unfunded vaccines. And so one of the areas in which pharmacists are quite interested in is around travel medicine. And I think we're going to see more and more pharmacies offering travel medicine services. And there's already a number of pharmacies who are certified by International Society of Travel Medicine who are working in collaboration with prescribers to provide those services. And then another program in which pharmacists have had a pretty significant role is with the herpes zoster. So based on some discussions I've had with colleagues and the drug manufacturer, there's been at least 100,000 doses distributed or administered by pharmacists in BC, and that represents about 85% of total doses that have been sold or administered in the province. And despite that being a pretty good number, that's still only a very small fraction of the total population who would be eligible for this vaccine. So I think it highlights that there's still a long way to go in terms of how do we get better uptake of these non-funded vaccines. And some of the things I think that have contributed to some of the positive uptake of this product include the amount of education and promotion that have happened around this vaccine, health professional recommendation, whether it's physician, pharmacist, public health, and then obviously all the promotional activities that pharmacies typically take when trying to promote a product. So bag stuffers, flyers, personalized letters, posters in the actual pharmacies. So for me, what are the main roles of the pharmacist? One is obviously to act as an immunizer of both publicly funded vaccines in various contexts, as well as an immunizer for unfunded vaccines. I think they also have a role in terms of being an educator, so providing accurate information about immunization-related information, And I think that role is actually one that probably needs to be explored a little bit more, because unlike the physicians and the public health and nurses who have a defined, I guess, responsibility to talk about funded and unfunded vaccines, pharmacists don't have that developed just yet. So I think that's something that we may have to look at as we go forward. And then the traditional role of pharmacists as a facilitator or seller or dispenser of products, that's going to continue as well. So when it comes to meningococcal vaccines, what are the opportunities to use pharmacists? When it comes to the C conjugate, I think the role of the pharmacist could be to immunize those who have been partially or who have not been immunized through traditional routine routes. When it comes to exposure situations, at the discretion of the health authority, pharmacists could be used if it happens to be that they are the most convenient source of immunization for the patient or the public. When it comes to those who are medically at high risk, there have been some situations where a prescriber or public health has recommended that a patient go to the pharmacy to get their immunizations, and that's more for the publicly funded products. And possibly a role that pharmacists will play is with the B conjugate vaccine, which is not publicly funded at this point. So they're most likely the ones who are going to have to sell or administer that product. And then obviously with the other recommended but non-funded indications for the quadrivalent and the B conjugate vaccine, pharmacists would be a reasonable place where patients would go to get those vaccinations. So last thing is just, what are some ways in which we can, contribute to improved uptake? Building relationships is important. So, as prescribers or as public health, if you get to know your local pharmacies, you can, get them to stock certain products. You can get them to be, or encourage them to be up to date on, certain diseases or vaccines that you think you're going to be recommending patients to go see them about. And then when it comes to education and public awareness, I think pharmacists, we traditionally rely on public health or BCCDC to develop education and promotion around most vaccines. And so I hope that continues, although I think there could be more done in this way with regards to unfunded vaccines. And then the last thing is around communication. That's an area that we can all continue to work on. And I'm hopeful that at some point we're going to have interoperable systems so that we can reduce the amount of duplication, triplication that's required to send immunization information back and forth to prescribers or to public health and vice versa.
Thank you very much, Bryce. You can ask Bryce questions now, or we can wait to our panel, which is going to begin in about 20 minutes from now. Probably wait from the looks of anticipation for lunch. So thank you, Bryce, and thank you all presenters. We're going to take a bit of a break, and we'll convene in 15-20 minutes for our working lunch with basically everybody you've heard already this morning, except for Mark LaBelle, who won't be joining us by teleconference. And hopefully we can chat at the break as well, if you have any questions of any of the presenters.
Sitting here, tech, 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 tech. Yes. So you can do a master's. It's pretty hard to Yes, yeah. Doing lunch and then just coming back to your session. Okay. No, that was okay. Good. Yeah.
Check 1, 2. I think the best choice is using the wireless mic. Yeah, the reason why is the mic is go the other side. Even though I try to talk right now, it's not loud enough. The wireless mic is like one side. I can also set up another one, so have 2 wireless mic. Yeah.
And then the people that are remote, will they be able to?
Check, check. 1, 2. Check.
Okay. So,
and pass around the people who have this.
so these aren't working.
Yeah.
Okay.
Yeah. This one is more like for audience, because if you go the other side, it's not really picking up. So
We have to use those.
yeah.
Okay.
Yeah.
So it works like that.
Yeah. And also I have another one here. So wherever top, just pick up the one. Just top.
Okay.
Yeah.
So this one's Simon.
Yeah. Just pass around.
Okay.
Yeah.
So I'm going to give this one to you. So yeah, Bryce, Julie, Camson, we're sitting up here. That's Louise, she's up here. And Monica. You can bring it up here. It's a working lunch. I was smart enough to scarf mine down because I know how good I look eating food, dribbling down my chin in public, but yeah, we're all on here. Absolutely. It's a working lunch. Some of us who are more sloppy are also faster eaters, so got that out of the way. Simon is chairing this, but he's trying to get down that cookie.
Just pick up the mic and talk.
So these are dead.
This one is more for audience, so that side, not for the other side.
No. Oh, okay.
So just hold the mic.
Oh, okay.
Pass around.
Just hold it. It's already live.
Yeah, we can, yeah.
So we've got two mics, and I think Simon is chairing this session. This is basically going to be a working lunch. Simon's going to chair it, and then we'll finish off in an hour or so.
So I learned a number of things this morning, one of which is that for these not publicly funded vaccines, everybody has the best intention, but within those spheres of public health, family practice immunizers, and pharmacy immunizers, there are barriers, and perhaps we could come up with a better system of interacting with each other to ensure that it's not quite so difficult for parents who want to give unfunded vaccines to their children that they can. So, for example, who knew that I can't take my picnic cooler box with a vaccine in to Vancouver Coastal Public Health Unit and expect the active immunization to be done, the actual bit of sticking the needle into a limb, whereas clearly doctors, according to Bill, have a more cowboy attitude to that and will basically stick a needle from a cooler box into anybody. Is that correct?
I don't inject anything in my office.
And you know, the good old pharmacists have all been trained to give vaccines, but I've got a horrible feeling that doctors are never trained to give vaccines. It's just sort of assumed that we can do it. So public health nurses, the pharmacists, they will go on courses and have to presumably pass some sort of test that says they're capable to immunize, whereas the assumption is that doctors always can. It's a bit worrying. So although this is labelled as panel discussion, I'm hoping that everybody takes part in the conversation. I'm assuming that in the distance sites, people were clever enough to leave rather than just watch us eat lunch. But if there is anybody at the distance site still connected, by all means ask questions. So I'm going to throw this open to the room. So based on what you've heard this morning, how can we overcome barriers to make non-public funded vaccines more available?
Do we just hit our light and that?
Sure.
Okay. Actually, my question is to Dr. Noss, I guess. NACI, I guess, has recommendations, and I guess you recommend to the Minister of Health. And from there, Health Canada, I guess, acts. As a practitioner who has done a lot of outreach in First Nations communities, I find there's a real lag between what the province is doing and what NIHB, the Non-Insured Health Benefits branch of medical services, who look after our armed forces, our RCMP, and our First Nations people, that there seems to be a lag. Like they just don't seem to be up to what the provinces are doing. And I don't know what happens at a national level. And my experience is going Vancouver Island, Campbell River to the 5 First Nations communities that are north of Campbell River. And previously in Winnipeg, I used to fly up to God's Lake, and God's Lake Narrows were 2 of my communities I looked after. And I found that the public health nurse there, who was starved for information, was often, or the medical services nurse, I guess, she's not really a public health nurse, was not, like, she wasn't getting the communication, he or she. Yeah, anyway, that's my comment.
That's interesting. In British Columbia, I think we've got a lot of integration in terms of policies and programs for the 201 or 203 bands in the province. And in this province, if there's a provincially funded program, it's offered on and off reserve. There's no differentiation between, Aboriginal communities or on reserve communities. And I don't think that's the same everywhere in the country, because I don't know whether anybody here can speak to that, even though I think that that's changing as there's much more transfer happening. But all the First Nations nurses, if they're still employed by First Nations, and increasingly now it's First Nations Health Authority in British Columbia, would have access to all of the same vaccines and would be using the guidelines, the BC guidelines in the immunization manual, and they wouldn't differentiate between a First Nations child versus not, or adult for that matter. In terms of the military, I think that people, the military do look after their own, but my experience is that if anything, they're sort of ahead of things, certainly for their adults. I mean, they vaccinate against everything, don't they? Like multiple times. I'm sure that the Canadian military gets quadrivalent meningococcal vaccine every 5 years. And the children would be eligible based on where they live. So if the children are seeing a family doctor or a public health nurse for their services, they would presumably be vaccinated according to the provincial schedule.
The military has absolutely no problem with vaccine hesitancy.
No. No.
So there is I guess, a direct connection between NACI and the delivery of services to those NIHB receiving individuals.
I would say that, in British Columbia, those individuals receive vaccines according to the provincial program. So NACI doesn't buy vaccines, NACI doesn't distribute vaccines, NACI doesn't determine what the program at a provincial level looks like. They make recommendations at the national level, and then in British Columbia, those recommendations would be considered within BC and would go to our Communicable Disease Policy Advisory Committee. We would do a briefing note that sort of lays out the issues for British Columbia in the context of our own epidemiology and our infrastructure for delivering those vaccines. And then there's if that requires funding, if it's just a tinkering with a schedule, that can be done quite simply. But if we need $2.5 million or $600,000, we have to ask for that money, and that means the request goes through the Provincial Health Services Authority to the Ministry of Health, and then the Ministry of Health has to decide whether or not to fund it, or whether to, or not to put the thumb screws on the PHSA to fund it, which could also occur. And then it becomes a program that's applicable everywhere, on and off reserve. We have very few recommendations that are different for Aboriginals compared to non-Aboriginals. One is influenza vaccine, so all Aboriginal individuals are eligible for free influenza vaccine. And then the other thing is hepatitis A vaccine. We have a pediatric vaccination program for Aboriginal children on and off reserve for hepatitis A because of the recurrent outbreaks over about a 15-year period that largely originate on First Nations communities.
Thank you.
So other questions from the room?
Simon, I was going to say that, I mean, I think it's all about communication, isn't it, really? I mean, we're fortunate in the sense that I work in Chilliwack, we have 5 paediatricians. Now, we all work together in the same office, and we have the office at the hospital, so we rent space off the hospital to have our clinic on the site, which makes it much easier for us to do things that people in individual offices might not be able to do. But one thing we do is to meet regularly with one of the local pharmacies who has very close links with the Children's Hospital pharmacy, and we've discussed some of these things, including immunisations.
But to Claire's point about where family doctors get their information from the vaccines, it seemed conspicuously absent information that you get from your public health partners. So my question is, do you get good information about unfunded vaccines from your local public health?
No, and we've not really, even though they're across the street from us, we haven't really developed good links with them, and that's maybe something that I'll take away from this, and we should look at doing better.
So the health authorities, usually send out very good information updates, newsletters. But Tamsin, is that mainly funded vaccines rather than unfunded vaccines? Like, how much effort do you put into communicating unfunded vaccine information to the family doctors?
I guess it's always a balance with, where you're going to lose the reader. So I know that in general, they're very brief. They try to communicate updates. It probably could be more. And how we try to convey it is on our quick references and bag stuffers too.
I mean, CME seems a bit of a
it's fairly limited.
So CME seems a bit of a hit and miss way of trying to reach the majority of family doctors and community nutritionists, I guess.
It does take a while for the information to filter out, for sure. And if the information is going as a bag stuffer with vaccine supply, that's dependent on when you're coming in to pick up your supply and how often and that kind of thing. And this will vary across the province. I don't know, I'm not that close to programs in place in other health authorities. That's just an example of what we're doing.
I know, like I was saying, I only had heard about the meningococcal B vaccine because we had the Bexero rep in. And the same with the Zostavax uptake has probably been a bit better in our office, and that's mainly because it's just much more visible in the public media, and also we've had the rep come a few times, drop off pamphlets and stuff like that. But it's not, I wouldn't see non-publicly funded vaccines come up regularly in the journals that family doctors would regularly read, or at any of the regular CME events that we've had in the past year. And then I get emails from Vancouver Coastal Health Authority, but so far it's only been about flu vaccine and Ebola. Haven't heard anything, haven't gotten an email about non-publicly funded vaccines.
Where does pharmacy get their information from?
They get some information from public health, but mainly around funded vaccines, and then they get information about non-funded products probably through their drug reps or whatnot. I think one of the challenges for us has been, typically we try to collate all the resources across the province for our members and just disseminate that to them. But part of the challenge is the way that each health authority communicates to their providers, whether it be physicians or pharmacists, is different. And so people don't know what type of information to expect or where they can get it in a consistent manner across the province. So, one of the things that I would like to see is a bit more consistency in terms of how public health communicates information to its community providers.
So I never know what is the health authority's role and what is CDC's role in providing communication for this.
We don't have any direct links to primary care providers, and I think it would be fair to say, Tamsin, that the very loudly stated preference by at least some of the local health authorities has been that they want to be the ones communicating to their own providers. And so, and as well, when we do communicate important issues through the BC College mechanism, which is something that Harry Kendall periodically does, he really likes to reserve it not for information items, but for very important things, like when it was related to flu pandemic, that was used as the route of communication to physicians. Maybe around Ebola, he would have sent stuff out, but it's not just it's not used as a distribution list for information from BC CDC. So it is possible to sign up for updates to the BC CDC website. You can go on and put in your email address and receive updates. So every time we post new information, for example, in the immunization manual, you would receive an update. I know that I've got lots of updates sitting in my inbox that I never get to, but at least that's a way to be on the distribution list when we update information on our website. But we don't communicate directly to providers. We periodically do surveys, attitudinal practice surveys, and so on. But this is very different from where I worked in Ontario, where virtually all vaccines for young children are given by family doctors. And there we used to do a direct mailing from the ministry to family doctors, like 13,000 family doctors in the province, and that was done from the provincial level. But it was there was a direct vaccine distribution system to providers straight from the ministry, and there was also communication sent. Whereas here, it's all channeled down through the regional health authority, and that's basically the mechanism.
So also, I feel very uncomfortable that I'm hearing that a lot of the direct communication is from the vaccine manufacturer, and how, is there a role for the BC Pediatric Society to fill that gap? And that's easy to make a case for something like meningococcal vaccines, but of course the BC Pediatric Society is not remotely interested in zoster vaccine for the elderly. And it seems...
Oh, yes, they are.
And so, to invent yet another player to provide information without considering all of unfunded vaccines seems to me a bit of a mistake, but presumably Bill and Stephanie have a different view of that.
Well, certainly the BC Peds Society has been, I think, a tremendous advocate for vaccines in general and non-publicly funded vaccines in particular, but I don't know that we have a broad reach. I mean, we communicate with our members, but I don't think we necessarily have a broad reach, for example, with family doctors, with health authorities, public health, for example, pharmacists. And so I'm not really sure it should be our role. I mean, we're going to continue to be involved, hopefully, with projects with BC CDC and with others to come up with resources. But like Simon, I find this somewhat disturbing. I mean, everybody basically here has said, where do you get your information? And certainly a lot of us do get it through industry. I said to one of my esteemed colleagues earlier about a vaccine that obviously we haven't been detailed on because we didn't realize it was licensed already. And that's disturbing. And I think there is a role, I would think there is a role for BC CDC. I'm not putting Monica on the spot because I appreciate that we're hampered in this province by the way things are divvied up. But personally, I don't like the idea that somebody in Northern Health gets a different bunch of information than somebody in Vancouver Coastal versus Interior, and I'm not sure that's really the way to go. I find it somewhat frustrating. I'm not saying it's wrong, but somewhat frustrating when you say, Tamsin, that you won't give a vaccine that's brought in, but you will sell this. Some other health authority, or maybe not even a health authority, but maybe even a health unit will do it differently. And it's just seems to me very, very fragmented. I would like to see something that could be done about that.
So I think I have a question about the BC Immunization Committee, and I think there's a few people who sit on it, and could they not play a larger role in getting this communication out? I think there's members from all of the health authorities on that, as well as the pharmacists and some pediatricians. I mean, that seems to me to be the group that's coming together to talk about these issues. And could they not coordinate the communication that's going out a bit more? And we've got an immunization awareness week every April. That would be a key week, I think, to send some of this out to the frontline providers. It's a great excuse to kind of get it out and perhaps send them to the resources they didn't realize were available. But I do think it needs some sort of central leadership because, and a group that spans all of the vaccines, not just pediatric vaccines, for it to really be effective. And I think we may already have a structure in place, but I'll turn it over to someone who sits on the committee who can.
You're right.
Well, I think that one thing we need to think about, though, is that we do have a guideline or policy at that committee that does spell out what public health will do with recommended but unfunded vaccines. So if we're just talking about quadrivalent meningococcal and meningococcal B vaccine, I would not put those in the recommended by NACI category. Now, right? Now, well, NACI says depending on the epidemiology of the disease. And so I'm not trying to say that it's not, well, I don't think it's as clear cut. That's what I was trying to say in my presentation. You know, NACI doesn't have a threshold above which it should be recommended. The fact that it's available, I think, is known on our website. We certainly do have information about unfunded vaccines on our website, including whether or not they're recommended. So, you know, people can avail themselves. The vaccines that are recommended but unfunded right now, probably key examples of those would be the zoster vaccine and HPV vaccine for boys, as well as HPV vaccine for older women, because NACI does recommend it more broadly than it's publicly funded. So we know that there's a need for that information to be available. But just going back to trying to standardize what health authorities do, I think one of the issues for health authorities, and Tamsin can speak to this better than I can, has been that if they're not funded to do something, then they either need to have a cost recovery mechanism, and many of their offices aren't set up to take cash, which is what would there have to be a financial transaction in order to provide that service, and it's also much harder for them to plan for that. So I know that that's been a barrier with respect to providing clinical services at the public health unit for things like travel vaccines or things that they would have to pay for. And then just going back to, I wanted to mention that NACI also has a sign up. So you can, if you want to be receiving updates, whenever the National Advisory Committee on Immunization publishes a new statement or updates the Canadian Immunization Guide, you just have to go to their website, enter in your email address, and you'll be on the distribution list. So some of this is really, you know, if you want to receive updates, and this is where information is posted, you can sign up, you can subscribe to those updates. I don't know whether there's, I mean, we can certainly have this discussion at the BC Immunization Committee about standardizing what public health does, but what was quite clear is that public health would use available information, and oftentimes for an unfunded vaccine, that's not going to be stuff that's been produced by the British Columbia Immunization Promotion Group. We don't, right? Tamsin, you're on that group. And that's a group that does have access to $500,000 budget per year for immunization promotion in British Columbia, but that budget I don't think has been spent on unfunded vaccine programs. It's been on funded vaccine programs. So there could be a discussion about producing some materials that could be used, because I think the approach in public health has been to make the information available, but not to spend publicly funded resources on providing that information. So if there's a poster, they'll put it up in the waiting room, and hopefully, while you're sitting there for 10 minutes waiting for your appointment, you will see it. But it's not an active discussion that takes place when the child is coming in for their routine vaccinations. Oh, by the way, there's also meningococcal. I don't think that that's happening right now.
I would say it's probably more of a passive approach, like you mentioned. It would also be based on risk and the type of client that's being seen. Yeah, I mean, across the province, there's some health authorities are practicing based on routine program and others are practicing based on history. So there's a difference there too, and the opportunity to talk about the private sale vaccines depending on how the services are set up. One question I have is, how do you want to receive that information? What kind of formats, what detail? Because I know we always struggle with that as well. And if we could get some feedback on that, that would be helpful.
So I've got to say, I have a huge problem with that sort of passive attitude. Like, we will only give you the information as a parent if you ask. And I think in your presentation, you said there is an obligation on public health in the same way as CMPA does about unfunded but recommended vaccines. And I think that's the problem with the NACI statement on MenD vaccine, is that we can't put it into the category of NACI recommended, because it isn't. And yet, certainly from the pediatric perspective, we would want that information to be given to parents to make a decision. And obviously you're, Tamsin, you're speaking for Vancouver Coastal, and not all health authorities are the same. But the discussions I have with parents is that they find a barrier at public health, and they say, no, we're only interested in routine schedule. Even if you try and make an appointment for a catch-up schedule or something unusual, it's very difficult to get an appointment.
And that's the difference between practicing based on history and practicing based on the routine program. That's some of the differences.
Yeah.
That varies.
And so, you know, I'd much prefer to see the sort of open access, which I think pharmacists are the sort of chink of light where, you know, that might be possible. But it's concerning if pharmacists only get their information from the manufacturers, because there should be some sort of communication stream from public health to pharmacy for the, you know, not yet publicly funded vaccines.
Well, I mean, I guess in defense of PCCDC, I mean, they do include those recommendations, you know, in their manual, and I think that's where we point. I mean, that's where we point pharmacists to as gospel, kind of is that's where you should get your immunization information. So, I guess as a professional organization, what we have done is we've taken the role of being kind of that person in between who will give that information to our members.
Yes, the manual does contain pages on vaccines that are recommended but not funded, not publicly funded. So the guidance is there on how to administer vaccine and contraindications and so on.
But you've got to be a very motivated family doctor to be able to look that up.
Yes.
Like, it's not being presented to
No.
them. So I guess my point from the discussion so far is that there are communication streams, but they're utilised, particularly by that communications group, for publicly funded vaccines. And surely it wouldn't be that difficult to piggyback this other information onto those communication streams. It's just that public health tends to put its hands up and say, no, that's not our remit.
Well, for the Immunize BC website, which contains the information on unfunded vaccines, if there's an update to that, you'd have to be a subscriber to receive a push notification. We don't have an email distribution list of physicians in the province.
But the health authorities do.
Health authorities do.
I would have to say, as the GP, like to echo Simon and stuff, it would be great to have some sort of central circulation about updates on non-publicly funded vaccines, along with like the flu vaccine, the Ebola, and all that coming from the health authority. Like I think we're all on the email list for health authorities to have that, and then because one of the biggest barriers is education for GPs. Like, you know, we don't necessarily want to get all our information from industry, but it has to come out of somewhere. And the journals we read wouldn't be the scientific journals. It would be the Canadian Family Physician Journal, BCMJ. There hasn't been any information through that or through any of our CME events. But certainly if we can centralize that information to come through email, that would be one way. And then through Immunization Awareness Week to, again, bring that up again during that week would be a good way for that information to be disseminated to GPs, because we won't necessarily go, I use that Section 7 on that manual all the time, but I would only go to that once I'm aware of the vaccine. I would never go there just to read the list of vaccines that are available.
I'm not sure that health authorities do have email addresses for all their physicians, actually. Yeah. As far as I'm aware, I'm the only paediatrician in Fraser Health who uses their Fraser Health email as their primary email, for instance. So most of all the information that gets disseminated to people who get given their Fraser Health email, whether they use it or not, doesn't ever get seen by any of the physicians. I don't think any of the GPs in our community use it either.
So I talked over Mel before. Mel had a question.
I look at a different topic. I'm just not quite. Is there a legal concern if one recommends and gives meningo type B, and it's not recommended? So if you give the immunization to a patient and they have a bad reaction, and they then start, the parents start looking at why you recommended this particular vaccine and it's not recommended.
Well, it is licensed, and I would say it's not being publicly funded because it's not cost effective.
No, I don't mean publicly funded. I just mean it's not recommended.
Yeah, but it's not being recommended because of safety concerns.
Yeah, so that's what I'm worried about.
And actually, the NACI statement is very well worded in that respect. Like it recognises that the vaccine has value for the individual, but they're making their recommendation based on epidemiology and the public health. So I don't think there would be any concern if you've had the discussion as to why you think this vaccine is worth giving. You will have had some discussion about the safety profile. So no, I cannot see any medico-legal concern.
I'd have to agree. And I mean, most of these, quote, not recommended, it's not that they're not recommended, it's just that nobody has recommended them that they be used on a population basis. It's not like Japanese encephalitis vaccine, which has significant side effects, so unless you're going to really high-risk area, don't get it type of thing. These are safe vaccines, and the decisions are made because of cost primarily. I mean, there's really no significant side effects, at least up till now. I mean, with somewhat limited data, like hundreds of thousands of doses, fever, that's not a reason why your child would not get this vaccine. I think if you were worried about your child getting meningitis B, you would not have any difficulty at all about giving them the vaccine serious. And I do have trouble with the terminology. I mean, like Monica, when you say like quadrivalent vaccine is not one of the recommended ones, well, that's part of the problem with the NACI statements, and the ambiguity of the CMPA recommendations is to follow the NACI recommendations. What the hell does that mean if local epidemiology warrants? I mean, I know that there are other physicians at this table who either have had the quadrivalent vaccines for themselves or their families, even though they're, quote, not on the recommended list. And so I've got some difficulty with this, and I really think it is a problem. And there clearly are some, I mean, that are really very easy. I mean, we know that at various provinces, they're considering funding towards, I mean, everybody would like to fund Zostervax, for example. I mean, I don't think there's any argument that it's only not being funded because of money. But in fact, if you really look, most of the vaccines are only not being recommended for money in a sense, or the logistics about getting them out there, basically. I mean, if meningitis B was 3 cents a shot, you could bet tomorrow we'd probably have a provincial vaccination thing, even though it's an extra bunch of doses. Zostervax, it's just money. I mean, like, there's no reason why it's not provincially funded other than money. Is that fair? I don't know.
Yeah, I do think I have found it difficult to read NACI statements lately. The prime example of that for me is I don't know how many of you have seen the PCV13, so the Prevnar recommendations for high-risk adults, which are stratified by levels of evidence. So there's a large group for whom they say the evidence is fair, and then there's a large group for whom they say the evidence is insufficient, but you may choose to do it for other reasons. How do I interpret that sentence? If insufficient evidence, but you may choose to do it for other reasons, which, so I think it is, and it's a conversation that I've had with NACI, because it becomes very difficult to know how do you actually translate this into a recommendation. Now, how would the CMPA view that? If the CMPA says that once something is recommended by NACI or the Canadian Pediatric Society, you as a provider should make your patients aware that it's available. And NACI says that there's insufficient evidence. Does that mean you should make them aware that NACI says there's insufficient, but you can do it anyway? So, but I agree that with the meningococcal B, the primary issue really is the cost. And I think what would have been worthwhile in that statement, and I was part of the group who authored it, but I think seeing what JCVI, which is the UK committee, did made more sense, which is that this is something that's worth doing, but not at any price. It has to be the right price, because I think if it's more explicit about under what circumstances, whether it's incidence of disease or whether it's cost at current incidence, is much more clear about what the trigger for a population-based program would be. I agree that once a product is approved for use and has indications in the Health Canada approved monograph, then you can administer it. And I think as long as it's being done with informed consent, and you're not giving it to someone who has a contraindication, then there shouldn't be an issue around liability per se.
So I thought the numbers presented by Bryce in terms of the numbers of needles going into humans in British Columbia delivered by pharmacists is very impressive. Like it looks like an exponential rise. Is it the view of pharmacists that is it the view of pharmacists that they would like to be immunizing children under the age of 5, irrespective of whether it's a recommended or non-recommended vaccine? Yeah. And then I'm going to turn the question to Monica from a registry point of view. How can we improve the flow through of who we know has been immunized in the province, whether they're recommended or non-recommended vaccines, because that is eventually going to play into how you interpret epidemiology. So, Bryce first.
Yeah, so we did a survey, I think, of our membership maybe a few years ago, and that was one of the questions we asked, is whether they would be interested in providing immunizations to those under 5, and the responses were mixed. I mean, there was, and I think it was actually more in favor of not doing it. But I mean, obviously, there's going to be some individuals who will want to do it, and also if we look at the surveys from quite a few years ago, before pharmacists were immunizing, if we asked them, do you think that you'll be immunizing, we would have probably gotten a similar response. So I think it's possible, and I think as the association, I mean, we can take a leadership role in either pushing that agenda, and I think eventually pharmacists would get on board with it essentially.
I mean, pharmacists are very good at writing down what they've given, because you're good with registries. Yeah. The immunisation registry, has been an issue in BC, but I think it's going to be even more of an issue when we start doing more and more of these not recommended vaccines.
I would say that communication, even if pharmacists document, communication is still a challenge. I mean, Monica knows that. I mean, getting pharmacists to report on and providing immunizations to those under 18, which is a requirement in most health authorities, it's a challenge. So I mean, I think that's still an issue that we have to address at some point. And hopefully, if we did have a central registry, or if our system spoke with Panorama, then maybe that would be improved. But until then, I think it will be an ongoing challenge.
Well, just on the registry side, there is definitely interest at the Ministry of Health in connecting information systems and using Panorama as a repository of immunization records from other sources. So the key ones would be the EMRs in use in the system. There's about 5 software companies, I think, I'm told, that have electronic patient care systems that physicians in the province use. And that's one source. The other one would be PharmaNet, even though the discussion there has been that it's a billing system, not a clinical system, but I think the intent is that it represents accurately what was actually done as part of the service. There's also the data sitting with MSP, which is the physician billings data for vaccines for individuals under 19 years of age. And we've just received, we're just in the process of receiving a linked data file to look at how accurately what physicians record as billed for vaccines for young children reflects what's in Panorama as the child's immunization record assembled by hook or by crook by public health, which is easy for public health to do when they're the immunization service provider, but not so easy when it may be one or more family doctors or walk-in clinics and so on. So we want to validate the accuracy of that information before potentially beginning to import that into the registry, which is what Manitoba does. You're the MIMS person, so Manitoba has a billing system, physician billing system.
And it is the MSP here, but in Manitoba it was the, whatever theirs is, MHSP. But they pick up all information for the MIMS in Manitoba from that, and I guess in Saskatchewan as well. And that's not happening here. And it's most unfortunate, having worked with MIMS. I said to you when I came here 15 years ago, it was, where is it? And I talked to the health nurses and that, and they said, well, the big city of Vancouver isn't tied into Panorama, and there's complications that's going to happen. But I came here about 15 years ago asking that, and it's been ongoing for 15 years. But could I just ask pharmacy? I have a degree in pharmacy as well before I went into medicine. But I just want to know, how does that pharmacist document the side effects of the vaccine? And what do you do if it's beyond the scope of what you can handle? Do you refer to public health then for that child to see public health? Is that the route that happens?
So I guess if it's a reportable event, pharmacists are supposed to complete the adverse events following immunization form and then send that off to their local health unit.
So that's the one that's in the CPS?
No, that's for drugs, but for immunizations, they will use the same forms that public health uses when reporting on adverse events, and they'll send that to the health unit, and the health unit will, I guess, eventually provide them recommendations on what to tell the patient. In terms of treating the patient for the adverse events, I mean, I guess if it's beyond their scope, they would send them on to a physician or a hospital, I guess.
Okay. So,
yes, I had a question with the pharmacist. What happens if the child will have their anaphylactic reaction to the vaccine in the pharmacy office?
Yeah.
Do the pharmacists are prepared to provide the treatment?
Yeah, I mean, I think the standard protocol for most pharmacies would be if you suspect anaphylaxis that you would treat with epinephrine right away, and then you would call 911 and then take comfort measures until they arrive. Yeah, but yeah, they are required to do that. Yeah.
And my second statement would be supporting Simon. Statement about how we are going to spread the information about the non-funded vaccinations. And here in this updated, there is a comment that a meningococcal B vaccine is now approved for use in Canada. And as a pediatrician, I start to worry about the legal issues, because I had the comments from many parents who the majority of children are vaccinated in the public health offices. And parents just in the office were reading the pamphlet about the Voxera, and they said, oh, why the public health nurse did not tell us there is other vaccinations available for my child. And in the completely hypothetical situation, you have a child who has died of meningitis group B at age of 5, 6, 8 months. I'm not sure the parents will come back and say, fine, why you were not informed that this vaccine was available.
I know this has come up definitely. I'm not sure it's a medical legal issue per se, because the CMPA is very clear that a physician that would be judged by the standard of care in the community of physicians around them. But it happens with vaccine preventable diseases too. You know, we had a child die of a Prevnar 13 serotype at the age of 5 after introducing Prevnar for young children, but after being unsuccessful in getting a catch-up program for children through our Communicable Disease Policy Advisory Committee. So, you know, in theory, that's a preventable case as well. And I think the way it's explained to me by people who work at the ministry decision-making level is that those kinds of decisions are within the domain of the Ministry of Health to make about what will be publicly funded and what not. I think what's more difficult is, you know, it's interesting because I think we in public health are very concerned about people who are refusing vaccines. What you're seeing are people wanting more vaccines than we even provide, and that's something that we actually don't hear about because we deal with exactly the opposite problem.
I've recommended patients who, parents who would like to be informed how I can protect my child. I have to go to work, my child will go to daycare full time. I have to know what else I can do to prevent, and I have a lot and more discussion with them.
And I think that's important because I think it's easy to assume that people aren't going to take up some of these vaccines, but there are people who do want this protection, and I think they're there. And it is difficult because I think, Monica, you're right, in terms of a public health issue, vaccine refusal is probably a much more serious issue. But, you know, for those who are believers, I mean, absolutely. I want to be up to date with my immunizations. I certainly want my kids to have the benefit of all the extra immunizations out there as well. And I think we do have to be prepared to provide this. And I agree, it's not so much a medical legal thing. I mean, I've also seen, I fortunately haven't seen death from Prevnar 13 strains, but I've seen, you know, a kid having a piece of lung taken out that could have been prevented, and it's distressing. It's not something that parents are going to sue, but would have been nice to have prevented that. And I think it's a very difficult issue because, as is with not just vaccines, any new medical thing, any lifestyle stuff, any improvement, just to get that communication out there. And even if you do get it out, I mean, it's not necessarily that easy to go and get the Prevnar. I mean, even let's say it's, you know, you saw something while you just missed the Prevnar 13, your kid is now 5 or 5.5. I can't remember when it came in. I think probably it's close to the time when most kids will have had it anyway, tapped up. But go try and get it prescribed. You have to go to your doctor. You have to take time. You forget to go. And you just sort of, and then, then you have to go to the pharmacy, get it. If they're above 5, I guess you can go now, but if 5.5, you can't. And certainly even with the quadrivalent meningitis vaccines, I didn't get my kids immunized right away, not because I didn't want to, but life gets in the way. And then getting the vaccine from the pharmacy, finding out they don't have it. So these are all very important issues.
So I think everybody on the panel is saying the same thing about wanting to get better information out there, but we seem to lack the tools to do it. So I heard, you know, the very, it wasn't said casually, but the taken for granted way in which pharma, through reps, provide information to pharmacists and to family doctors, probably less so to pediatricians, but that's an anathema to public health. They're just culturally
they're not supposed to talk to reps. So my question is to the panel, what is the role of the vaccine manufacturer in this state where a vaccine is licensed, may or may not be recommended by NACI, but isn't in public programs? And for rotavirus vaccine, for Prevnar for a long time, that was the situation. And I think people feel uneasy about this relationship with pharma, but I value the panel's views on, in this situation, what is and isn't acceptable for the manufacturer to do. We'll start with Julie as a parent.
Can I speak as parent? Well, I guess I would just say that I find it frustrating that we can't get, and actually I'm thrilled that that HealthLink sheet is up from NB. A few years ago, I'm not sure that would have been there, so I do see progress on that front in terms of what's coming from public health. I think there needs to be more for the approved vaccines, regardless of the NACI recommendations that none of us can really make sense of. I think it's nice to have an alternate source of information, particularly for parents who may be sitting on the fence. I get a lot of questions from people, and it's very nice to be able to refer them to the Immunize BC website as a somewhat, unbiased source for this information when they're seeking it. And I think for public health to put a hat on that says, I'm only going to talk about the publicly funded vaccines, does everybody a disservice. And I wish that the immunization nurses would feel more comfortable talking about it when they see parents, because the study after study after study show the influence of the healthcare provider, whether it's the family doctor, the public health nurse, or the pediatrician, making a recommendation and taking the 2 minutes to talk about this new vaccine. And so I don't think we should discount that. And I do understand, wanting to be judicious with public money, but I think public health is playing a larger role in this that can't be stopped at whether or not the vaccine is put into a public program. And I think maybe the communication around this needs to get separated out from, what's publicly funded and what's not, because I think by putting up those somewhat artificial barriers, the parent doesn't really care. They just want the information, and they'd like it from a source that they trust. And I think that sort of as public health, we should be providing it. I'm putting myself in the public health camp, even though I'm sort of more in the academic, but I think it needs to be coming from somewhere. I feel very strongly it needs to be coming from somewhere other than the manufacturer.
So we do provide the information, but we provide it on our website. So we don't have a mailing service to physicians' offices. And we've relied a lot on the branding of Immunize BC. There's been a lot done to draw people to that. There's a lot of social media activity. We've got the I Have Immunity and the immunization boosters and so on and so forth. And we do have content there about unfunded vaccines. So I think there was a question asked and we didn't hear it, and probably we don't have enough numbers in the room to think that you are representative of what physicians in the province want or how they want to be informed. But how do you want to be informed? Because the traditional way in British Columbia, and that's still the case, is that we've got the website, you can subscribe to updates on the website, but in terms of stuff that's coming to you in either with your vaccines as you receive these from local public health, or in a newsletter from your local medical health officer or public health unit, that's done at the regional health authority level, and that may not be standardized with respect to the type of information that comes to you about unfunded vaccines. So, are there ways to, I've heard that there's some desire to have standardized communication. What that would mean then is that we would have to say to health authorities, can you please send this information out to all of your physicians? And some would probably do it and others may not, because they'll think that they're overloading their inbox, or they want them to focus on what's really important, which they'll consider to be something else. I think that's certainly the experience we've had. You can comment.
No, I think we need for sure more feedback as to how to do it and how much and what to do, because we do struggle with that all the time. Exactly what you said. If we send too much, then people stop reading, and what's considered valuable and not. And so we do need some more feedback on that. We've provided a few tools that I shared with you to help facilitate talking about publicly funded and unfunded vaccines. This conversation has made me realize that I need to go back to our nurses and find out what the activity level is. I need to check in on that because I'm not sure. And also our parents and the public, how many questions are they asking about that? So I think I need to do a little bit of work around that. But we have provided tools to facilitate the conversations, and we've also informed our nurses about their obligations to speak to the privately funded vaccines.
So I would point out that the HealthLink BC health file for MenB vaccine says the vaccine is recommended, but not provided for free. So I know you're trying to simplify the language, but that seems to be a pretty good endorsement that it is recommended by public health.
Can I, sorry, go ahead.
When parents go to public health, they get the immunization schedule just with the funded immunizations. And I think it would be very good to give parents this kind of schedule, so at least they are informed and they can ask the pediatrician. So this is a simple piece of paper because they only get this part. And if they have this, at least when they come for growth or development or whatever, they can ask us questions, or they can ask the family physician questions. A lot of parents, some parents are informed when they ask, but a lot of parents have no idea that those immunizations exist, and we not necessarily inform them if they come for other reasons to the pediatric office. I think this kind of piece of paper for the parents will be very important because they can ask us questions. At least they have, that's a point of discussion from the beginning.
Sorry, just getting back to your question, Simon. Maybe it's an overly simplistic perspective, but I think that the drug manufacturers do have a role in terms of increasing awareness. Obviously they're going to want to do that because they're trying to sell a product. But if as providers, whether it's a pharmacist or physician, if you agree with some of the statements that are being made in whatever promotional materials that you've given, so you've vetted that content, how many, it can have a huge impact in terms of increasing awareness. How many physician offices, how many pharmacies do you see posters for herpes zoster vaccine, right? So obviously it can help improve the public's awareness of the product, but obviously the provider needs to have an unbiased source to create their opinion, right? And so I think that's where BCCDC and Immunize BC, those are good sources of information. So I hope that they will continue to provide more and more information about these unfunded products.
Claire, from funded practice point of view?
I think, the same way, GPs, by and large, probably don't want the majority of their information to come from drug reps. And the information that we do get through drug reps are vetted. Like you say, we take what they say with a grain of salt. We might then go do our own research, validate it, but it would be good to have some sort of centralized way to receive the information. I don't know if the health authorities can access emails through the College of BC website, or through the College of BC if they can get all the family physicians' emails from there. I think the reason why I probably get Vancouver Coastal emails is because I have privileges at VGH, possibly. And I think the majority of the physicians at our office have privileges through some of the other Vancouver Coastal sites, which is probably why we get our emails from Vancouver Coastal about the flu vaccine and Ebola. And then I think signing up for those websites, the BCCDC website would be great. And I know we often refer to the BC Immunize schedule through the HealthLink, but that one only has the routinely publicly funded. And then I know there's a few asterisks like Hep A if they're Aboriginal, but it might be good to enhance that schedule a bit more. Because I know I always refer a lot of parents to HealthLink, and that's a very government-sponsored, public health-sponsored, unbiased information that GPs feel comfortable referring to. So to add that on to the side of it. And then I know parents often bring in their little immunization booklets that they obviously get from public health in some form. So if they could include in that package maybe some information about recommended but non-publicly funded vaccines in that, so at least they could read up on it. And I think for most GPs, building into their daily consultations with the baby vaccine checkups or the Roy checkups, to have those health link sheets available. I know that amongst GPs we have this source called Dropbox, where we've centralized all our doctor information sheets, patient information sheets, and referral sources, clinical tools and stuff. So it would be great. It's a good way to wrap up a consultation at the end too. We could just type up, non-publicly funded vaccines, print out a sheet, give it to the parents, and then have them recalled for a separate appointment where we actually have the time to go through the pros and cons of the vaccine with them. I think that's what GPs need, and that's probably how it's going to work in the reality of busy clinical practice.
Actually, can I just say about the communication? I practiced in Campbell River. Comox North is looked after by one MOH, and I think that communication should be the responsibility physician to physician through the MOH. We had a wonderful MOH, Charmaine Enns, and she had all our emails, and she both snail mailed us and emailed us. And we were always communicating. She also came to our medical staff meetings at least 4 times through the year, whether it was in Comox or Campbell River or Port Hardy. She made an attempt. And so I think that's an MOH responsibility, and I think that their role, if they need to, needs more money put to it to make that communication happen.
Yeah, newsletter and email to cover both those aspects, I think would be useful.
Simon, do you think there would be a role for doing a one-off mailing through the college to all family physicians and paediatricians, reminding them about their responsibilities with regard to immunisations and identifying where all the information so that they could be updated was available?
So you mean BC College?
Yeah.
So that's usually the, it's Perry Kendall, but as Monica said, it tends to be for the,
stuff you must
flashing
do.
Red light.
If we think this is sufficiently important, which I think everybody who's here would agree that it is, would that not be worth doing?
I think I would be speaking about it, about using one of these tickets for this.
Well, the college do a college connector or something. I just got an email 2 days ago. So that might be a good place to say just a reminder, CMPA, policies are issued.
So this isn't so much an autocorrect as corrected because Bill kicked my shin and said, you should have read the second half of that paragraph, which was the vaccine is recommended but not provided free. But it does go on to say for those who are at risk of meningococcal B infection, including not having a spleen. So I was wrong. Sorry. Mel.
Another question about meningococcal B. The old vaccine was stopped because of serious side effects, and so that still lingers a little bit. It's like the rotavirus was stopped because the initial one caused interception. Now the vaccine B apparently is made differently from other vaccines, to my understanding. And so I'm just, perhaps for myself to recommend B to patients, I need sort of reassurance that the new technology that's used for vaccine B is actually tried on other vaccines and that it's perfectly safe. Basically because the first vaccine was had serious CNS side effects.
Well, I'm not sure it did. It was just it wasn't very immunogenic. And it wasn't immunogenic because of immune tolerance. And so it was more of a theoretical concern than a proven concern. And usually those vaccines were introduced in the setting of major outbreaks. And that's where they use the outer membrane protein vesicle in a Cuba outbreak, a Norwegian outbreak, and then subsequently in this New Zealand outbreak. So the capsule vaccines never went beyond the preliminary trial stages. They were never licensed as far as I know. And so the component vaccine, like the idea that this reverse vaccinology, which is new with this specific vaccine, but it will be the shape of things to come, the message is that they're using very specific proteins that hang off either the outside of the bacteria or part of the bacteria itself. So it's a component vaccine. And I think the public are sophisticated enough to know that that is going to be safer than the old, boil the bacteria up in a test tube with a bit of formalin and stick it in your arm, which was the old whole cell pertussis vaccine. And so I think, we do spend an awful lot of time dealing with the sort of 12 to 15% who are not very keen on vaccines, forgetting that the 85%, as Anna's saying, actually want more vaccine, please. And so I think it is possible with this new technology to be even more reassuring about the quality and safety of vaccines.
Okay, thank you. That helps.
I would just say if it's a new way of identifying the vaccine antigens, but I think that's really, to really simplify reverse vaccinology to the way an epidemiologist can understand it. I think that's really the new thing about it. So the way, what they do with those antigens after that is not new or novel, and it's been done since the first vaccine. Well, maybe not since the first, but at least since the middle of last century. So, but how they found those antigens is what is new about it.
So the audience has been asking questions, I've been asking questions, but the rest of the panel, any other questions that you want to give to the room or to the other panel members?
So I love doing these things because I tend to learn a lot as well. And one of the things I learned was, and if I'd given it any thought, I probably would have come to this conclusion myself, but it was brought to the fore today. GPs are not reading vaccine, and they're probably not reading Pediatric Infectious Disease Journal. So I'm going to ask the pediatricians in the room, what do you read? How would you like to know about this stuff? If you've got something coming out, what would be the best way to get it out so you see it? We've done some things in the CPS journal, which the name has totally just left my head. Child health, thank you. Pediatrics and child health, but what do you look at?
Children health journal. We have every month, and it's quite well. It's not a big piece. Yeah.
Well, you're on the editorial panel, are you?
No. That's a good question. I mean, I think there's part of the problem is there's so many resources. I mean, the BC Medical Journal comes every month, and it's got really quite relevant articles and really good stuff. Have I read many of them? No. You've got the CMAJ, you've got the Child and Youth Health. That's a pretty good one, actually, because it's got very relevant type of things to pediatricians. And more so, I can usually open it electronically, which I can't with a lot of the stuff that comes through the email that you'd think would be easy, but somehow the 20th time that the password got lost. One thing that, we could certainly disseminate a bit easier, I was just thinking, Stephanie's here from BC Peds, at least to disseminate to pediatricians. I mean, certainly, we could put those links, for example, to BC CDC, the new things, links to NACI statements, and we can certainly put those types of things in our newsletter, because I think our newsletter is read, but maybe that's just because I'm biased, but it's kind of flashy and it's easy and it doesn't come out terribly often, but of course it doesn't go to family doctors. But I don't think there's one thing that, I don't think, I could be wrong.
Medical Post?
I used to when I got it, and when I got the hard copy, I used to read that. Because I'd always want to see who's holding it up in some exotic locale, but I don't even read that anymore. I don't know that there's...
What about Twitter? Does anybody in this room rely on Twitter for any information whatsoever? Because we recently had a discussion about, probably your generation, because we recently had a discussion about should we be tweeting more and what kinds of things should we tweet and who is picking up those tweets anyway. I know it's considered to be sort of easy, and I have a Twitter account, but I've never used it. I haven't figured out how to. Does anybody use that? No.
No, but Facebook might be
My favorite thing for review is the College of Physicians and Surgeons library section where they break it down into peds and
The sites and
gastroenterology.
bites?
And if they had
Sites and
I'm
bites?
sorry, that's okay. And there, if they just did a section on immunizations, I think that would be great. Those women are fabulous.
I think also with the CME events, like having a talk, like, you know, a compilation of what we did today. Like, for example, there's the Family Medicine Postgrad Forum at the end of February, where like tons of GPs attend this. It's a yearly thing. Yeah, to speak at that would cover like a huge amount of general practitioners, because it is hugely relevant and it is one of those scary illnesses that GPs don't ever want to miss. So I think that something like that would be helpful in combination of obviously putting it into reading media and stuff like that. Yeah.
And the same question to pharmacists. What's the pharmacist's main access point?
No, actually, our college doesn't really send out much information. I mean, I guess probably the association, we have actually very good readership in terms of our weekly communications to our members, as well as we have like a bi-monthly kind of magazine as well. And then similarly, like professional journals like Canadian Pharmacist Journal and things would also be places to put those kind of things. And then we have an annual conference as well. So those are all avenues which each pharmacist at.
But of course, the question is who's going to be responsible for the content, and I would like to think it would be BCCDC. Yes.
Content and all these things, or
well, if you're going to push out information about new unfunded vaccines like MenB vaccine, should that information come from BCCDC or should it come from the health authorities? Who is the best person? I suppose that is a topic of conversation for the BC Immunisation Committee. Communications section.
To be continued. I think something I was thinking much specifically around disease burden, because that's what I do. Disease burden and incidents, and that type of risk communication, which we did around MND in the CPS journal. But I'm recognizing there may be a need for some of that for the pharmacists now and for the GPs clearly. So, you know, if it's something that I know something about, I'm craft some of that or craft however, certainly the larger communication piece is beyond what I would do. But I think there's probably room for multiple types of as we did today, everyone talked on something slightly different, but it all fits together into a whole. So I think there's room for probably all of that.
I guess I have a question, not related to this, and I don't know if we have the right people in the room for it, but I mean, I think the cost of these unfunded vaccines is obviously a barrier, especially at $100 a dose or more. So I don't know if I guess it would be the ministry, but are they still exploring other ways to fund vaccines? So I know there's been some discussion with Pharmacare in terms of covering the zoster vaccine. I don't know, that didn't go so well, but I don't know if the ministry is still exploring those types of avenues or also talking with private payers to get some of these things funded. I mean, I think the ministry has quite a close relationship with Pacific Blue Cross, who's the largest insurer in BC. So I don't know if that's something that should continue to be explored. I don't know if you have anybody in the room that can really speak.
So I do know that the PHSA, extended benefits does not cover vaccines, which I've pointed out to various CEOs in the past that is rather embarrassing. And I was told to shut up.
I'm going to follow through on that, maybe put Monica on the spot. For things like HPV, which we negotiate, you negotiate very good prices for the publicly funded program. Why is there no way to extend that price to privately bought vaccine? I mean, if a boy comes in and wants to be vaccinated, that's recommended, no question, we would recommend that. And yet we say, no, go and buy it at a pharmacy at this price. We can't give you this even.
So that's really not a question for us, that's a question for the industry, because we have clauses in our purchasing contracts that prohibit us from reselling at cost. And I presume that those clauses are there because the industry wants them there. It certainly isn't something that public health would have thought of putting in there. you don't deal with that side of the business, right? Very convenient. But anyway, that's the truth. That's the truth. That's exactly.
Maybe that's something we shouldn't be signing. I mean, I'm just saying, I mean, obviously they don't want you to know how much they sell it for, but maybe that's something to be looking into for some of these vaccines, because I think truly, if we're trying to encourage uptake of vaccines, it's truly discouraging to say, well, we can vaccinate this, but your sibling who's 2 years older, she's no longer eligible for the public program, so she'll have to go to a pharmacy, all the hassle of bringing it in. We can't sell you this, we can't not only give it to you, we can't even sell you a reasonable amount. Maybe it's something we really should play more hardball. I'm not sure.
I can raise that as well. Yeah, definitely. And I think the other question, I don't know whether anybody in this room, I don't have an answer to that. How do you get Pacific Blue Cross or Sun Life to ensure vaccines? I'm not sure what criteria they use to make that decision.
Well, I mean, I guess one way, I mean, because I think Pacific Blue Cross is the insurer for most government employees, if that's right. I mean, because the government is paying the bill, but essentially, right, they should be able to influence, you know, what those insurers cover. So I don't know if that's an avenue.
It goes to the price of the premium. So the insurance company would be more than willing to cover it, but they would charge a price to do that.
Are travel vaccines covered?
By some insurers, but by and large, I would say it's a small number of insurers who actually will pay for vaccines at this point.
But I think the pharmacare and the Zoster vaccine story, of which I presumably know a little bit, is very interesting. So if you thought the Zoster vaccine was a good idea for the elderly of BC to get, but you wanted to add it to pharmacare, one of the advantages would be that you could negotiate a price with the manufacturer. So it was sort of on formulary sort of thing. But clearly that's a very complicated process.
Yeah, and we haven't been involved in that process, but.
In terms of, I was just going to say, in terms of vaccine uptake, the one thing in the UK that dramatically improved vaccine uptake was paying family physicians extra money for giving vaccinations, and that was the one thing that got, when a whole new tranche of immunisations came in the late 90s, we were well below the herd immunity level. That was the one thing that really made a big difference.
Yeah, I think we could offer bonuses to public health nurses if you got population rates above a certain amount. Yeah, incentivize, isn't that the North American term?
I thought you were going to suggest fee-for-service billing for public health nurses to give privately purchased vaccines.
Yeah, I'm all for that too.
Pharmacists can do.
So I think Bill is going to wrap things up.
Sure, let me wrap things up. So I'd really like to thank everybody who attended today. Much appreciated coming out on a Saturday. I don't know if it's still foggy out there or whether it's a nice day in Vancouver. Just a few notices. First of all, there's some evaluations, and certainly appreciate if everybody would fill one of those out on the way out. This is accredited, so they should be filled out. These presentations will be archived on the BC Pediatric Society website, which is bcpeds, bcpeds.ca. If you remember, you'd know that, but it's okay. bcpeds.ca, so bcpeds.ca. I'd really like to thank Novartis for sponsoring this through an unrestricted grant to the BC Pediatric Society, and Laura Moore-Dempsey in particular, who's very helpful and helping us do a lot of vaccine projects, which we think are important. Certificates of attendance will be sent by email from the BC Pediatric Society. I'd just like to thank Laura and Simon and for helping plan this day, because a lot of work went into it. And just in terms of, I think a lot of things were brought up today that are really very interesting and maybe give us something to move in on. Obviously, there's more room for education with respect to non-publicly funded vaccines and publicly funded vaccines. And I think this session pointed out how important the collaboration between various professionals is to really get the message about vaccines out there and make sure that our population is as vaccinated and immunized as possible, and really how difficult and challenging it is, the dissemination with respect to information on this. And I think that's something that's very key, and it's something that we really have to come up with. And probably BCIC is going to be discussing some of these issues, hopefully, and maybe see what we can do to improve things, and so that perhaps when you come to one of these next time, we'll be much more aware of what's around. I really like your idea of maybe distributing the BC Pediatric Society immunization schedule more widely. Perhaps I'm biased because I was involved in partially creating it, but a lot of people here were very involved in reviewing it and much appreciated. And I think it just shows how important it is to get the information out there and in an easily accessible source, because we are so busy with so many things. And immunization, though important, is very one small part of what a lot of us do in a day. So thank you again for coming, everybody.